presenting perinatal mental health 101. Birdie is a nurse with a master's in psychology and counseling. She was the founder of Perinatal Mood Disorders program at Indiana University in Indianapolis. She is certified in perinatal mental health and is internationally known expert and speaker. She is a past president and past co-chair of education and training for the Postpartum Support International, and currently serves as the director of certification and training. PSI is the world's largest nonprofit organization dedicated to helping those suffering from perinatal mood and anxiety disorders. Birdie is also on the advisory council for PSI and for the International Childbirth Education Association. She specializes in the recognition and treatment of pregnancy and postpartum mood and anxiety disorders. Birdie is interviewed frequently for radio, television, and print media. She is the co-author of a book chapter, Behavioral Health Science with High-Risk Infants and Families. Birdie is highlighted as a PhD expert in PSI's video that is shown around the country. Healthy Mom, Healthy Family, Understanding Pregnancy and Postpartum Mood and Anxiety Disorders. Birdie has been speaking to audiences for over 25 years and is an international trainer for the PSI 2-day perinatal mood disorder components of care. A fabulous training, I might add. And the advanced psychotherapy 1-day training. She also speaks frequently to communities, nursing schools, grand rounds, and conferences. And we are incredibly lucky to have her here with us today.
You're so sweet. How many new people in here that have never heard me talk?
We're in for a treat.
Welcome, newbies. But a lot of you have heard me talk before. Let's see, came back for more. But you know, this is a good training today. So she said all that to say who I am. I've probably been doing this longer than 25 years. I'll have to figure that out one of these days. I don't know. So that is me. How many nurses I got in here? How many therapists, psychologists, counselors? We have any physicians? You go. Thanks for coming today. Woo! How about advanced practice nurses, midwives, nurse practitioners? Yeah. Home visitors. We couldn't live without you, home visitors. How about doulas? You know we couldn't live without the doulas at all. Gosh, we love you at the bedside. When are we going to finally say that it gets paid for by everybody? I know, already everybody needs a doula. I told a cousin of mine when she was pregnant the first time, she said, what's the first word of advice she would tell me that's absolutely necessary? I said, give it to her. Yes. And she said to me after she had the baby, oh my gosh, that was the best advice you could give anyone. But you know what? Right now, it's only the privileged that can have one, and we've got to stop that because they make such a difference at the in and out. I'm fanning on you. Who'd I forget that's here?
Lactation.
Hello, lactation. So am I. I'm not the gold standard. I'm a CLC. So you IB-CLCs that are here, God love you. I never went on to do that because I got so busy with this.
Health educator.
Childbirth education, health educator, gotcha, yeah. So I call myself an OB know-it-all, and I just told my granddaughter who lives here, oh yeah, because she's working on her nursing degree, and she only thinks of me as an OB nurse, and I said, I started out as cardiovascular critical care, and I would never want to be an OB nurse. Do you hear me? That would be the worst of the worst when you're an intensive care nurse. Lordy, you are like bossing everybody around. I got to OB and I was like, I went to the manager and I just said, I don't think I can do this. These people are all so nice. It's just a totally different world, and I'll talk about that on a whole later level, but it is. But I fell in love with it, and I'm so happy that I ended up in OB. And then one day somebody came to me and said, do we have anything for postpartum depression? And I said, why, no, we don't, but I'm the OB nurse with a master's in counseling, I'll look into it. And I went to PSI to get training, and the rest is history. I got involved. I worked at IU Health, statewide 15 hospitals. I worked mainly in Indianapolis with 5 hospitals and set them all up with screening, because what do we say to people before they go home from the hospital? If you find yourself crying a lot, be sure and call your doctor. What if I wake up anxious? What if I wake up mean as a snake? You didn't tell me to watch for that. So make sure you tell them baby blues last 2 weeks. That's it. They don't have the baby blues at 6 months. They have the baby blues for 2 weeks. After that, if they're still not themselves, something else is going on. Eating disturbances, sleeping disturbances, make sure you're giving them real basics of what to look for instead of just, and in childbirth ed class, and anytime you cross the path of a childbearing woman, person, a postpartum person, please be doing education. They don't know what it looks like. So we'll hit that. I speak all over the country and the world, and I have to show up outside the US. I don't, because they don't care who the colds are. But here, here around the US, I do brag on some colds country. Remember, 1 in 5 to 7 women will develop a perinatal mood disorder, 1 in 10 men. What does that mean? Some of you could be triggered today. This is a trigger warning. I'm not speaking to a church group, mom's group. I'm speaking to professionals who want to hear the truth about a perinatal mood disorder. I get an hour and a half, 90 minutes. I can talk for half a day. So I'm talking fast and quick, and I hope I leave time for questions. If not, you can email me, you can get a hold of me. Vision of PSI is that every woman and family worldwide would have access to information, social support, and informed professional care to deal with the mental health issues related to childbearing. We promote this through advocacy, collaboration, and by educating and training the professional community and the public. Acknowledge diversity in this room, and anytime you're in a room, would you please? Would we please note that almost all research to this point has been done on white heterosexual couples, just like heart disease studies were done on men for years, and we didn't have a clue as women what we looked like if we were going to have a heart attack. So we're getting better. We're doing very few studies on LGBTQ+. Starting to do a little bit, and I'm actually updating our curriculum right now to where women have agreed to rewrite slides and look for more research. And then what we're finally finding out about racism and how it's affecting our birthing people. So honor the differences. You're going to hear me use different language, mom, dad, parent. Our dad's coordinator said to me, after the years where it was constantly, you were told to say partner, partner, partner. If we don't say dad, don't say husband. Finally, he came up, Birdie. Dang it, you can say dad sometimes. There really are dads. And I'm like, okay, I went a little overboard. So we do have parenting, and families look so many different ways, and we've got to acknowledge that and try to change our language. Language is always changing. What do childbearing women and people need? A companion or advocate to provide support during pregnancy, birth, in the first year. Who is that? A doula. Okay. Supportive professionals who are knowledgeable. That's everybody that crosses their path. And if we don't have professionals who are educated on this, then we get people turned into CPS for intrusive thoughts. We get 911 called on them. It's happened in the physician's office. 911 is called after I get many calls, Brady. I think we got somebody in here with psychosis. Okay, tell me the story. No, that's intrusive thoughts. Just let me talk to her this afternoon. Here's what I want you to do. You see, I'm a bossy intensive care nurse. OB nurses don't talk like that. They're just really sweet. I did finally fit in. They got used to me, but not all of them. Some of them were just, oh dear, Birdie. Having a time and a place to talk about your pregnancy, your birth, and the continuing postpartum experience. Hopefully, that's all of you. It's the #1 medical complication related to childbearing. I'll prove that later with stats, because people say, where's the reference for that? I'll show you. It is an opportunity to help women, pregnant people, postpartum people, to know their prior undiagnosed. How many of you are normal or come from normal families? Raise your hand high. Oh, look at you liars back there. You know, occasionally somebody will actually do this. I think so. And then they're the one that call me later and say, I didn't realize till I heard your talk what I had. Yeah, I know. You know what? As one of our really highly acclaimed reproductive psychiatrists says, none of us have a clean history. Okay, so please listen to me right now. Y'all got something. You know, it's very rare if you don't. You got a major malfunction, accept it, know what it is, and learn to be best you can be with it. Quit thinking you can go for a run and make it go away. Okay? I don't run anyway, so I'm not running mine off, and I accept mine. My girls, at my family reunion, you know what we say to each other? Ain't none of us right. Now, you know some of us are worse than others, but ain't none of us right. And we just accept it. We talk about what beds we're on. We really do. Seriously. In my family, no one's on Zoloft. No one. Not one person. Isn't that funny? We're not a Zoloft family. And we talk about what Zoloft did to us when we went on it. It wasn't good. But other people, Zoloft's great for them, okay? And then the people in my family who have bipolar, they'll talk about what meds they're on, and they're kind of all on the same things too. It's really interesting. So my girls knew their diagnosis by junior high. They weren't getting out of this. They had my family history on my mother's side, and they had my husband's history with OCD, intrusive thoughts, my side, depression, bipolar, both sides, alcoholism, substance abuse. No suicides on either side, but lots of other things. So they know their diagnosis. They both got intrusive thoughts. Risk of untreated, we know the ACOG bundle. Relationship problems, exacerbation of medical conditions, interpersonal violence, which you're going to hear about next. Finances, disability, unemployment, child neglect and abuse, developmental delays, more nicotine, more alcohol, more substance use, lots more smoking weed. I got a text from 2 of my trainers that are in Lakewood, California, and they said, we cannot get food delivered to the room, but we can walk across the street and get some weed or anything else we want out of the dispensary. I said, have a good time. Also, what's the most important? Infanticide, homicide, and suicide. That's why we can't ignore this. Suicide, one of the 3 leading causes of death, is what was said in this in 2003. We now have the CDC, and this is an old CDC. This was the one before the most recent one. And we have found, both Dr. Arnaudo and I are on the Maternal Mortality Review Committee, and we sit there month after month. Who else is on their maternal mortality? Good for you. It's hard work, isn't it? Ooh, it's hard to listen to all the maternal deaths and why, and we ask questions, and could this be this, and could this be that? Was racism involved? Was mental health involved? Was substance use a part of this? Was that on purpose? Was that accidental? Was that suicide? She ran through a red light. Do we know? Does she have a baby under a year? Could have been she ran it on purpose. But we don't have a note, we don't know that, do we? So it's all very complicated, and we find out. So the CDC has started putting together these. And what's right at the top? Mental health and substance use disorder. So we got a lot to work on, and that's what you're hearing about today. What are the costs that leads to increased costs? And some of the things I just mentioned: discontinuing breastfeeding early, family dysfunction, and affects brain development. Here's a study showing that we found 50% of the women with antenatal depression and 30% of postpartum. But look how many got treatment. Because you know what, we hand them a piece of paper, or we hand them a big old book saying, here's who takes your insurance. They have phone anxiety, they can't even follow through and make the call, and they say, oh, it'll go away. I've had people call me and say, Birdie, I've had your card for 6 months. You gotta help them with that phone call. Have somebody help them make the phone call and make it. And there's nothing more discouraging than to call 5 places and say, I'm no longer taking new patients. Don't make them go through that. Help them find where they're gonna get resources. That's the hardest thing to do. We call it perinatal mood and anxiety disorders. Everybody else calls it postpartum depression. That's what your clients call it. If you're Googling, you're gonna Google postpartum depression, okay? And that's okay. I would never tell my Uber driver, if I'm in town and I'm gonna tell him the truth and I'm not in for an air conditioning conference. If I'm gonna, I mean, I make up stuff sometimes, because you know, if you say you do whatever you do, you might suddenly have somebody start telling you all their problems. No, I kind of wanted a nice ride without you talking to me. So, but if I do say, which I did one time, perinatal mood and anxiety disorders is what I teach on. And what is that? Is that PTSD? One of them said that. I did do it twice. Another one said, huh? So if you say postpartum depression, everybody goes, well, that's a real thing, isn't it? Yeah. So that's what you get. So 80% of new mothers experience baby blues. At least 1 in 7 experience serious depression or anxiety. 1 to 2 have postpartum psychosis. Our psychosis survivors in PSI have asked us not to use the word rare anymore. Don't say psychosis is rare. It's less common than depression and anxiety and OCD. But please don't say it's rare, because then no one looks for it. And it's happening in 1 to 2 in 1,000. And you all heard the story. If you didn't, don't go look at it. A woman who 3 of her kids died just a couple months ago in Massachusetts. So because of her psychosis, and she tried to die herself and didn't pull that off. So 1 in 10 fathers. So ACOG, they've got their statements 1 in 7. I mean, they're just saying the facts. 1 in 10 men. It can affect anyone, no matter your resources or your money. Serena Williams says, not only was I accepting some tough personal stuff, but I was just in a funk. Mostly, I felt like I was not a good mom. And I love that our celebrities and our stars like this are coming out with their stories. Alanis Morissette had us have a table at every one of her concerts last year to advertise perinatal mood disorders and postpartum support international, and put it up on her big screen before she started and at breaks. So isn't that cool? She just speaks out. We have so many people speaking out. So we've got to get the word out so that people know where to look. When we say postpartum depression, it means it's only depression and it's only in the postpartum period, which is not true. We still have people that say, well, once she has the baby, she's going to be fine. No, she's not. She's going to be worse. Please, we've got to treat during pregnancy. It's not all about crying. It doesn't mean you're going to kill your children. Some people don't fall in love with their babies right away, okay? We say that at support group, closed support group, you are allowed to say whatever you want. And they can say there, I didn't fall in love with her. I mean, I love her, she's my baby, but I'm not madly in love with her like everybody said I would be, right? Who puts that on social media? Hey guys, I didn't fall madly in love with her like you told me I would. I don't feel anything for her. They'd all be over her front door thinking she'd lost it. No, she needs to say that in the closed Facebook group where it's okay to be honest. I screamed, shut up at my baby at 2 a.m. I feel such like a rotten mother. And then I say to the group, anybody else ever yell shut up at their baby? And everybody in the group, like half the group, yep. Oh, you guys, thank you. I mean, it's just, that's what group is so wonderful for. You guys notice that my head is attached to my body? You notice this? Why are we treating our high blood pressure, our gestational diabetes, but we aren't treating this? What's the stigma about this? What is wrong with the fact that we think this means we're crazy? I shouldn't need that. It's okay if you need meds, but I don't need them. But I wouldn't argue with you about having a stroke. I'm going to take my high blood pressure meds. But no, oh, Birdie, you telling me that I need to take a medication is like asking me for the foreign substance in my body. You just told me you smoke weed. Really? And so she says back to me, I know, but it's natural and from the earth. Okay. We think it doesn't happen during pregnancy. We think it's going to go away on its own, and they come back to see me, and they've been depressed or anxious since their last baby 2.5 years ago, and they're now pregnant again and say, I can't do this again. Something has to be wrong. Something's not right. They don't say when they wake up, I think I got postpartum depression. They say something's not right. I haven't been myself since baby's been born. What's the myths? Motherhood and parenthood. It's going to be easy or hard. A lot of people think they'll never get pregnant, and some get pregnant because they're not using birth control. I was told I could never get pregnant because I have polycystic ovarian syndrome. I was told I'd never get pregnant because I have endometriosis. Well, you're pregnant. And so they weren't using birth control because that's what they thought their OB care provider told them. No, they said it'd be harder, unlikely, but did they really say never? Also, the couple who told me they were going to get pregnant in September, have a baby in May, and both teachers are going to take the summer off together. Let me know that's working for you. 50% of pregnancies are unplanned. We have myths about becoming a mother and a parent, about being pregnant, about labor and delivery. That's all we think about when we're pregnant. Really, when you teach childbirth ed, they don't listen to you in the postpartum period. They don't listen because all they want to hear about is labor and delivery. And then they have that baby and they're holding it and they all say the same thing. I'm sitting there thinking, I don't know what to do now. What now? And they used to say when I worked on the postpartum floor and I'm wheeling them out, Birdie, you're coming home with me, right? No, I don't know what I'm doing. Do you know that? Yep. Like if we could just walk around all the time and see a pregnant person and go, your life's about to change forever, you have no idea. But it wouldn't be nice, would it? First of all, don't ever assume someone's pregnant or ask them unless you see crowded. Because once you have said, were you delivering, which I said, and she wasn't pregnant, you can't take her back. You can't. No. It's out there. You just said, I thought you looked big enough in this area that I thought you were pregnant. And when she's not, you can't say, I'm really sorry. No, you can't say you're sorry enough. That was the rudest thing you could say. Just don't say it. Unless she tells you she's pregnant, don't mention it. We think the baby's going to sleep all the time. We think breastfeeding's going to be easy. And perfectionism gets in your way. Those of you who kept it together and kept your house together and all neat, which I never was, so that wasn't a shock. But honestly, those of you who do, like my friend who says her house is a mess and it means there's a newspaper on the floor, okay? You're gonna fall apart. They're gonna fall apart because they can't believe it. There's my sweet daughter and son-in-law, who 50% of pregnancies are unplanned. They're very smart people, but they got pregnant at 3 months postpartum. And that's a very busy house. And they just are, they're both, their birthdays are in May. And my Kensington just turned 5 and Jameson is turning 4. And they are close. It's gonna be hard when she goes to kindergarten next year. You won't know what to do. They've been buddies, right? From day one. You think you're gonna be happy all the time. There's myths about this can draw us closer together as a couple. Here's the truth. You argue more about stuff you never argued about before. I do everything. You don't do anything. I need some help around here. If you ask that new birthing person, what do you need? They'll say like, I don't know, I'm just overwhelmed. So you work with them to find out what would it take to help you. We have to come up with solutions. Here's what I teach. You tell someone, no matter whether it's your partner, your mother, your friend, would you please take my towels out of the dryer, fold them and put them in the linen closet. If you just say, would you take my towels out of the dryer? People will do that and put them on top of the dryer. Now, if you got a problem with how they fold the towels and you have to refold them, that's another story and some more therapy, okay? Selective memory, those are the people that I think my baby slept all night long. Day 5, I wonder why your baby's not sleeping all night long. You have selective memory. My children sat still in church. That's what a woman yelled really loud, whispered loud to her husband. Well, at least our children sat still in church as my Beth was running Hot Wheels up and down the pews. She was making noise. She wasn't yelling, okay? Media images, everybody has a baby bump and little skinny legs. I never had skinny legs. I don't have skinny legs. I'll never have skinny legs. And I didn't have a sweet little baby bump. I was big all over, but that's our images, right? And Beyonce with her twins. How far along is she there? Let's guess. 3 months? 4 months? That didn't work. Here's what you look like pregnant with twins. This is one of our trainers. I have her permission. That's the day of delivery there in her gown. And this is one of my friend's daughters. That's what you look like pregnant with twins. That's what you look like postpartum breastfeeding with twins. Okay? I have permission of all my family and friends. Okay? All pregnancies are wanted. All pregnancies in a live baby. All pregnancy means love in the relationship. All pregnancy means a healthy baby, and all pregnancy means fulfillment. Let's look at it. How are we adjusting? Oh, this is it. New parenthood. Staring at your baby cooing back at you. Yeah, sure. We don't see the pictures of the baby screaming at 2 in the morning, do we? We have these sweet pictures, all planned, all set, smiling. Everything's perfect. They're all staged. Take a picture of us. Yeah. The next second, baby's screaming. They're losing it. But we don't put those pictures out. I teach a 4th trimester class and I have a whole Zoom room full. It's a free class, by the way, that anyone can come to. It's given by IU Health. It's given quarterly. Go look up on IU Health North, look up childbirth ed classes, and you'll see 4th trimester. It's taught by me quarterly. Anyone can join from all over the world. So I advertise it. It's free. You just sign up and she gives you a link. And I have all these, they recommend pregnant or in just the first few weeks, because once you've had the baby, you got to figure it out that isn't what I thought it was going to be. But they come and they sit there all sweet and listening to me and they laugh, but they really don't know right now. They're decorating the nursery and they're thinking about labor and delivery. That's it. Nothing beyond that. As women, we have this, I do everything, I'm the strong one, I take care of everybody, I won't need anything. And then that shock. Or those of you who signed up to work on your doctorate during your first pregnancy because you thought you'd have plenty of time afterwards, don't do it. And if you did, tell them, put me off for a year. In our lives, we have seasons of giving and seasons of receiving. When you are a new parent, you're in the season of receiving. And don't forget that. Tell your clients, you're in the season of receiving, not giving. You gave before, you'll give again, but give them permission. This is what you're supposed to be doing right now. It's letting people help you. It's not a weakness. Have a big long list on the fridge. When they come over and say, well, I'll do anything to help, what you need. There's a list on the fridge. Go help yourself. I don't need you to come and rock my baby. I can rock my baby. I need you to clean my toilets, to clean my house, to start dinner, to go to the store for me, to vacuum, to do whatever I ask you to do. Get me food. Hold my baby so I can take a 3-hour nap. When I'm pregnant, it is all about me. My estrogen and progesterone are as high as they're ever going to go, and then they crash down on the day of delivery. Up come oxytocin and prolactin, brings in the love hormone, brings in my milk, and whoa, that's what causes baby blues. That's it. That's simple. Okay, so when people say to me, so what really causes postpartum depression? Is it the hormones? Yeah, that causes blues. We just want to have a reason for it, don't we? And I'll show you in a minute. And you'll have your own diagnosis besides that. And I'm just always happy about that. We'll find out what you got. So preparing for parenthood, dreams and expectations, and it's not always a happy, glowing time. Now this happens, right? It was all about me. Everybody's paying attention to me. Now the baby's born. Now the focus is on forming the baby. Baby comes first. And the postpartum person, if they have the nerve, says to me, what about me? This is hard. I'm not catching on to this. Overnight, you lose all your freedom, all control of your schedule, and you don't have a clue what you're doing. You don't get to come and go anymore. You don't just say, I'm gonna run to the store. Sure, with a baby. Hey, let's go away for the weekend. Yeah, with a baby. or a babysitter, figure it out, you're no longer free. You will hear frequently, I want my old life back. I will never not be a parent again. That strikes them and hits them really just like, At group one week, one woman just said, you know what? I want my old life back. Just once. Just one Saturday, I want us all to pretend that I don't have this life, that I'm not a mom, and I want to get up on a Saturday morning and I want to smoke weed and watch cartoons. And I have no responsibilities. Everybody burst out laughing because everybody's like, I get it. You're never not. You are redefining one of the hugest role transitions in your life is becoming a parent. And you didn't know that. I am so sorry for those who are still planning on having children or are pregnant right now with their first because we're scared. Sorry, but it's all true. So, hormone changes, of course. Birth night may not have gone as expected. You're learning new skills. We taught you how to change a diaper on a plastic doll in childbirth ed class. We did not tell you that baby was going to poop all the way up to the back of the neck right after you got him in the car seat to go to the store. Role transitions, dreams and expectations of what you thought this was going to look like, what you thought your partner was going to be like, what you thought you were going to be like, facing fears and feelings, renegotiating responsibilities. Who's making dinner? Who's going to the store? Who's dropping off at daycare? Who's picking up at daycare? Who's staying home when the kids are sick? Things you didn't even think about. That's what I teach in the fourth trimester. You thought about these things? And you got lots to think about later. You're gonna make them clean their plate. How are they gonna, you just have all kinds of stuff. You just so many things later. Well, we didn't have to. Well, we did. And you're bringing so much into this partnership. Insecure, establishing feeding, physically and emotionally healing. So lots of losses, and you don't think about that, right, with the delivery. So I told you freedom, control, schedule, but also body image, career potential, finances, self-esteem. You don't know what you're doing, and you knew who you were before. You felt confident. Now you don't feel confident. And one woman said at group, I do group once a month for PSI still. And I love doing them, but I'm too busy to do anymore. And one woman said, can I just ask a question? I mean, I know this is hard and I know all that we're saying, but does anybody else ever sometimes just feel bored? Like they don't do anything. They don't give anything back. I was busy at work all day outside the home, and now I'm just like blah, 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 change another diaper, blah, blah, blah. And I mean, how funny is that? It just is. Well, to us, not to them. Not to them. Okay, that's what we all think we're gonna look like pregnant. Here's reality. Okay, reality is I still look like the woman in the green jumpsuit at 4 weeks postpartum. My mother-in-law watched the baby. I ran to the store, wanted to get out of the house. Cashier asked me when my baby was due, right? That's what I'm saying, don't ask. I was 4 weeks postpartum. Of course, I still looked pregnant. Some of you didn't. Some of you went home in your skinny jeans. Good for you, because you had little baby bump, skinny legs. That's why. Okay, here's the meat of it and your diagnosis. Let's look at it. It can be depression, anxiety, panic, OCD, post-traumatic stress disorder, psychosis, or bipolar. These can affect you at any time in your life, but when you are pregnant or postpartum, they ramp up and they look different. You already had anxiety, now it's about a baby, a fragile human being, and it feels different. COVID threw everybody over the edge. We had so many, the acuity of the calls were higher, lots of suicide calls, and in our groups, I had things like people saying, I was really feeling great, my anxiety was gone, and then COVID hit, and I'm back to where I started, all over again. It was awful. Study of 10,000 women by Catherine Wisner and others, 21% had postpartum depression. And her studies show that 1 in 7 developed during pregnancy, 1 in 7 in the first 3 months. But when they carried the study out for a whole year, 1 in 5. So that's why you hear me say 1 in 5 to 7. 68% of the primary diagnosis was depression, but what went right with that? 66% anxiety. So they hang out together. Many times the presenting factor you're going to see that I saw was anxiety. But you're gonna see depression with it, or you're gonna see depression, and you're gonna have a little anxiety with it. 22% were diagnosed with bipolar disorder, and 19% endorsed thoughts of harming themselves. Okay, the blues, I've mentioned. What causes it? Hormones. It peaks at 3 to 5 days. 80% of women develop the blues no matter where we study, in whatever country, 80% get the blues. Hormone changes. Overall mood is happiness, but they are tired, they're overwhelmed, they're trying to figure out what's going on. It doesn't last more than 2 weeks. They're shocked, right? Lost their freedom, lost control, don't know what they're doing. Depression, just what you know, sadness, crying, typically overeating, junk food, sugar and chocolate, oversleeping and still tired. Anhedonia, don't care about anything I used to enjoy. No joy, interest, or pleasure in my usual activities, blah. These people are not brushing their teeth, they're not taking showers, and they talk about it in a group with no shame. Well, they hate it. I haven't showered in 5 days. I haven't even brushed my teeth in 4 days. I can't take care of myself. I barely take care of the baby. I can't take care of my family. That's where, that's where suicide comes from, a sense of hopelessness. I'll never be myself again, and they'd all be better off without me. Guilty and ashamed. Birdie, why am I in your office? I have a healthy baby, a wonderful spouse, and a beautiful home. I'm so ashamed to be in here. I shouldn't be in here. We have to tell them, you're not alone. This is really common. 1 in 5 to 7 women, you're not to blame. Here's what your risk factors are, and you're going to hear them in a minute. We should be teaching them every time we pass. We have more than a few minutes. We should be telling them what the risk factors are. Or just saying, like, you got a lot of risk factors. What's that mean? Let me tell you. This just doesn't feel like me. Anxiety, overwhelmed. I'm so overwhelmed, I had no idea it was going to be this hard. If I'd known this, I wouldn't have a baby, or I would have waited 5 years. Sense of worthlessness. Okay, depression. Here's anxiety. Can't sit still, mind is going, worry, constant worry, racing thoughts, short of breath, heart palpitations. Then I go, oh, let's go back. Can't eat, no appetite. You see somebody, they have lost weight, 30 pounds in 3 weeks, and you say, well, look at you, got your figure back. No, she's got anxiety, that's not normal. Okay, just think right away, she's got anxiety. Ask her what she's eaten so far today. Now, what you'll find out sometimes is as new parents, they don't know how to eat. I don't know how to find time to eat. Somebody said that on group. I always explain it. You get granola bars, you get cheese sticks, you put out bowls of cashews, and you walk by, you throw cashews straight in your mouth. That's it. When you sit down to feed your baby, you have something to drink, and you have snacks next to you. Because you know what? People are bringing food. They don't have time to warm it up and sit down and eat it. And they don't get it. They're like, I don't know how to find time to eat. You have to teach them that. I don't know how to get sleep. You have to teach them that. Okay, they don't know that. They can't fall asleep. They can't stay asleep. They can't go back to sleep. If I watched your baby for 4 hours, will you be able to sleep? And they'll say no. Why not? You're going to hear, because if I don't watch the baby, he might die. I don't trust anybody else. Or you might hear, my mind won't shut off. It just worries all the time. So that's anxiety. Panic, I go into full-blown panic attack. Once I've had a panic attack, I panic about having another panic attack. My heart's pounding out of my chest. I have numbness on my lips, my face, my hands might go numb. They will describe it choking or smothering around their neck. They get chest pain, they end up in an emergency room, and what happens? They get told, no, you got postpartum anxiety, panic. 3 fears of panic, this is how they describe it. I thought I was dying, I thought I was losing control, and I thought I was going crazy. So it feels awful. Depression, anxiety, panic, and now we're going to look at obsessive compulsive disorder. So OCD, what do we mean when we say that? It means we're telling people they're real neat, right? They keep things in order, they're clean, they're germaphobes. So remember, all of us have a little bit of weird, quirky things we do, but those who really are diagnosed with OCD have a problem with not being able to even function. It's really hard unless treated. They can't get out of the house because they have so many routines to do. Classic OCD, cleaning. You got a brand new baby, now you're cleaning more. Now you're mopping more, you're vacuuming more, you're making sure baby's clean. You don't want anybody touching the baby. First of all, don't touch anybody's baby without asking. Don't do it. Strangers come up all the time. Oh, look at all that hair. Don't do it. Look at their little feet. Oh, and they do their hands, and then the baby puts a hand in the mouth. That mom's like, ah! They think their baby is contaminated, and they have to get away from you, wash the baby off, get all the clothes off of them, get them in the washer. Sometimes they're washing the clothes like 4 or 5 times in a row because they're not clean enough. This really gets in the way. Certain routines, checking, rechecking. Is the baby breathing? Is my house locked? Common thought, someone's going to break in my house and steal my baby. That's a common thought. Counting, some people have a counting thing. Some people have a sense of order, like I said. Towels have to be folded a certain way, or they have to do things in a certain order. And this really gets in the way, okay? The other way OCD looks along with it is intrusive thoughts. I clearly saw my daughter gray and dead under the water. I couldn't give her baths or take her swimming or put her anywhere near a body of water. What kind of mother thinks these things? My daughter would have been better off without me. Obsessions are defined as recurrent, persistent thoughts, urges, or impulses that are intrusive. Individual attempts to ignore or suppress them. And compulsions are behaviors that you feel driven to perform or say in your head, and their behavior or mental acts aimed at preventing it. So they are intrusive, repetitive thoughts, usually of harm coming to baby. What if I drop the baby? You've all had that thought. But someone with intrusive thoughts actually sees an image of themselves throwing their baby down the stairs. What kind of mom has a thought like that? You know, if you tell that to someone, they think you have psychosis, they think you're in harm to the baby. It's an intrusive thought. It came out of a place in the brain where they want to protect their baby, and it's taken and twisted and said, what's the worst that's going to happen? Heights, banisters, stairs, they might bump down on their behinds, bring the baby down the stairs. They won't go near banisters, they won't go near heights of any kind. Water, they won't drive over a bridge. They won't give the baby a bath. They're avoiding water. So heights, water, sharp objects. They take all their knives, all their scissors, hide them in a lockbox, put it in the back of the closet. That's their compulsion. Because they keep having images that they're going to harm their baby with the sharp object. It's a very vivid thought. Even now, I'm not going to give you the vivid thought, because those of you who have intrusive thoughts are like, please don't give me anymore. That's enough, right? You got it. It's a very vivid thought. It's very horrific. And in group, we ask you not to give your intrusive thoughts out loud. Just say, I have intrusive thoughts. You do that with your therapist. You tell them vivid images. Heights, water, sharp objects, traffic. Many new parents can't drive. 88% of new parents have intrusive thoughts. So 88%, both parents. So no, that's common, but if they have a diagnosis of OCD, it continues on. And it's very debilitating, and it's treatable. So another besides traffic is sexual thoughts. And those are the ones that you're going to be last to hear, because they are so ashamed of those. They also can have intrusive suicidal thoughts. Hear me, here's what it sounds like. Birdie, I do not want to harm myself. I do not want to kill myself. But I keep having a thought that if I did, how would I do it? And then I imagine all the ways I'd do it. I'm horrified by it. Why am I doing this? See, someone that didn't ask more questions might think they were really suicidal. They're not, okay? They're just not. But I know that's scary when you're running across this. What if she really does do it? Well, get some more training on this, because she's not going to, and she's not going to harm her baby. It's a thought, not a fact. Here's a video, and I'm so afraid I'm going to run out of time. But I'm going to show it, because this is a good one. I hope it plays. And if it doesn't, whatever, okay? But I just want you to hear somebody's intrusive thoughts. This is Shoshana Bennett, who's a psychologist in California and had intrusive thoughts, it tells us. I don't know how to do it. Let me see if I can hit it here. See, when I do it, normally it just plays, but I'm afraid that's gonna happen. Okay, you can find it on our YouTube channel. Just go to PSI's YouTube channel, you'll see all of our videos. And you can see her talking about it. It's only 2-3 minutes, and you can show it so that you can do it for education. But her name is Shoshana Bennett, Bennett. But if you go to YouTube channel, you see all of our, we call them PSAs. We have several 2 to 3 minute clips you can use for education, you can use to understand. So here's just a nice graphic. What if I drop her? What if she dies? What if I fall down the stairs? What if I drown her? Remember, they're having images, pictures, a movie playing, a story they tell over and over and over. So you want to say and normalize this. You know, sometimes new parents have scary, unusual thoughts. Are you having any? Normalize it with that statement, and then she might say to you, yeah, I keep thinking that my spouse is going to leave me and I'm going to be all alone to raise the baby. Or they might say, oh no, I can't say them out loud. They're so awful. You can say them to me. What are they? I've heard them all. They're called intrusive thoughts. Okay, so here's one for all of you. Driving down the highway, you're behind one of those trucks with cars chained up on it. You know what's going to happen? They're all coming off. Every single one of those cars are coming off. I don't want to stay behind it. That's an intrusive thought. Comes out of nowhere. You have images, pictures, a story. Common contamination, fears of deliberate harm, accidental harm, some religious, some checking. Gold standard is exposure and response prevention. Please do not do exposure therapy unless you're trained, especially with our women and men, anyone who has intrusive thoughts. Don't do it unless you're trained, have had supervision, have a consultant. It's not something you mess around with. CBT can work with negative thinking, but if you get a chance and you're a therapist, take ERP. It's a great treatment. It teaches them to learn to sit with the discomfort, right? And you sit and hold that with them, okay? Because just keep saying, it's not gonna happen. You promise me it's not gonna happen? You can't just keep reassuring them. I mean, believe me, I get texts from my clients that just say it over and over, having it again. You should, what if I go crazy? What if I really do it? I'm gonna go to ER right now. I think I might really do it. Okay, go ahead. I said one time, go ahead, go to ER. You know what I told you, that people in ER aren't gonna know what intrusive thoughts are. They're gonna send you to psych unit tonight. Like, I could talk to her like that, okay? I've been seeing her for a while, but she really just couldn't quit. Stop. It's a thought, not a fact. You know what we talked about. Let's just sit with the discomfort for a while here. I'm not gonna do that. So specialized training right there. Thoughts do not equal action. Okay, so you are saying this, right? How do I know that from psychosis? With OCD intrusive thoughts, the thought scares them. They are horrified by it. If you say, are you really, I don't want to do that, but what if I go crazy? Someone who has psychosis is out of touch with reality. They see things that aren't there. They hear things that aren't there. They think you're poisoning them. They think their baby's a demon. They say things like this, baby, my baby's eyes were glowing last night. I thought it was demon possessed. That's not an intrusive thought. You got that? But when I said what she said, it really scared me. I knew that wasn't a normal thought. So you can't go with, does it scare you? Because someone with psychosis and who thinks her baby is demon possessed will say, yes, it scares me. So that is not your go-to. You're asking more questions. You're assessing further. And if you don't have the experience, you send to someone who does. You have plenty of great therapists here who are trained. They're overly concerned. Psychosis, they may seem less anxiety. Andrea Yates drowned her 5 kids because she was evil. And they were, I'm trying to think what word she used, but she wanted to baptize them into heaven to save them all. That is totally a psychotic thought. But when she was doing that, she was protecting her babies. but it made no sense, right, to us. And so she is in a mental hospital, but we have people sitting in jails because of psychosis and things that happen because of it. OCD thoughts, they don't want to harm the baby. It's obsessive, it's odd and frightening. They've taken steps to protect baby. They do not have delusions or hallucinations. With psychosis, they have delusional beliefs. Thoughts of harming our ego syntonic. They think they're reasonable or they feel tempted to act on them. As many as half of primary care physicians may misidentify OCD, with 80% misidentifying harm obsessions. Nearly 70% of healthcare practitioners did not accurately identify obsessions of harming the infant, and 30% misidentified these symptoms as psychotic. We have an OCD support group. So make sure you send people with OCD or send yourself. It's actually for the first 2 years postpartum or during pregnancy. But all of our groups in PSI, and we have zillions of them, are led by people with lived experience. So termination for medical reason, people are there that had a termination for medical reason and know how they feel. They know how to relate with them. Early infant loss, people that have a loss are leading those groups, okay? Perinatal post-traumatic stress disorder. I really want this to play. That could be. You can try it. Let me see. But I don't, that could be. Okay. Sure, if it works. Anybody want to yell out a question right now while we're doing this?
What do you do when you have a patient in front of you that you think is psychotic or experiencing psychosis, I should say?
First of all, they don't leave your office. If you have a crisis team, you have them come. You ask more questions. And you call someone who has seen psychosis before, which you need to know who your good colleagues are that know things. What else? Help me answer that.
We also have our local mental health facilities.
Send them to the local mental health facilities to get evaluated and sent to somewhere that you know knows what it looks like, because sometimes they don't. You learn that real fast too. But you don't just send them out your door, do you? No, you got to make sure they get there. You call a spouse, you call somebody, or you might just call an ambulance to take them. If you think they're not, like we had a woman who, somebody had their spouse come and get them, their husband, and she tried jumping out the car and almost did it on the way there. So it's best just to have them transported by ambulance. Okay, let's see if this works. Nope. No, I don't know. It's funny. I've got them embedded and they play normally, so I don't know why. It happens at other places and I never know what that is. I need to have somebody tell me why it doesn't work when I do it. And maybe I should have hooked up my laptop because you know it plays on my laptop. But oh well. This is, let me tell you who this is, and you can see a million of these things. This is an Instagram woman that you want to follow, and the Instagram she has is called, let me think. It's Trauma Mama is part of it. Postpartum Trauma Mama. Postpartum Trauma Mama. Somebody look that up on IG and find it. Her name is Kelli Summers, and she had a very traumatic birth, actually what we call a near miss. She actually was coded twice and ended up with a hysterectomy. And so she talks, if you know of anybody who had a similar experience or had a near miss, but this is really just her trauma over and over and over, how she deals with it every day, that she'll never have another of her own. She'll never have another birth of her own. When people asking her, when are you gonna have the next one? But she does constantly post on Instagram, and it's interesting for you to watch so that you know what that feels like. What is PTSD? Remember this, it's in the eye of the beholder. It's not what you say, it's what she saw it as. You don't say, well, you know what, your baby's fine and you're fine, so let's move on. Well, that didn't seem that traumatic to me. You know what, no sentence ever starts with at least, do you know that? Well, at least, if you can hear at least, just tune out, right? And people say it to you too. You know God doesn't give you more than you can handle. Everything happens for a reason. I bet you're going to help someone else later on. Oh, that's really comforting to me when I am 3 days postpartum. Sarcasm intended. Don't do it. Don't give platitudes. Sit. Is Hattie here today? Oh my gosh, I didn't even see you right down front. Holding, Hattie. What was the other term? Holding space. You've never heard that term, holding space. You're holding space. When someone has a loss, you say, I'm sorry, and shut up. Everything you say after that is trying to comfort yourself. It's uncomfortable if you've never done it. You're just sitting with losses and you're holding space because they're crying. They're devastated. They've already planned that child going to prom. They've had dreams and expectations. You're holding space. Don't say at least. Birth trauma, an event occurring during labor and delivery process that can involve actual or serious injury to or death to mother, her infant, or the woman being stripped of her dignity. The birthing person may experience, and I'll go that in a minute. Here's some potentially traumatic perinatal events. Emergency cesarean, postpartum hemorrhage, prematurity, stillbirth, unexpected NICU, severe preeclampsia. They end up in intensive care. They end up losing their uterus. They end up being in intensive care for 2 or 3 weeks. They miss the whole first 2 to 3 weeks of their baby's life. They feel cheated out of that. They didn't get a bond. And look at all these traumatic vaginal birth, on and on and on, okay? Cheryl Beck, nurse researcher, found this. 4 themes. She interviewed several women with a traumatic birth. She found these 4 themes consistently. 1, you didn't care. You abandoned me, you neglected me, you stripped me of all my dignity. You didn't give me support or reassurance. You did things to my body without asking. You violated me, you raped me. Those are really common terms I hear. Think about it, doula. You're in a traumatic birth, it goes like that, right? We're all screaming and yelling, running down the hall, we're saying, do this, do that. They don't have a clue what's going on. The birthing person and her partner, if she has a partner, doesn't have a clue. The doula can say, here's what's going on, here's why this is happening, it's gonna be okay. You may not have anybody else in the room that's doing that. So if they don't have a doula, they're both just scared. Well, you're scared anyway, but they're not getting told what's going on. Okay, we're gonna now, someone might say, well, but not a vacuum extractor. What the hell is that? I've never heard that term before. You didn't tell me about how somebody pulled my baby's head out with an extractor. What the heck is that? Right? Poor communication. I felt invisible. I kept asking, is my baby okay? And nobody would answer me. I heard this over and over. I saw them. I heard them whispering above me. Feelings of powerlessness. You betrayed my trust. And number 4, did you have to do all this to me? Was it necessary? They want answers. They may not be able to talk about it for at least 3 to 4 months. They avoid postpartum care. They won't go, this is really typical. They won't go back to the same OB, especially if they blame them or they're angry at them. It all depends. They will not go back to the same hospital the next time they deliver. And if you have any help to help them, find a lovely, lovely OB care provider, help them plan their next birth, whatever they want to do, and help them write a birth plan First, they need to process this birth, and it may take quite a while for healing, but they should be able to be in control. I always contact the manager, a childbirth educator, make sure that people know this, she's coming in, she had a traumatic birth last time, and make sure that our OB care provider knows that. They may have elective C-sections in the future, or they might say, nope, this time I'm gonna have a good vaginal delivery, and here's what we're gonna do. They might still end up with a C-section, but they get to choose. I had one client on her birth plan that said this: do not touch me anywhere, even if I am numb. I want you to tell me when you're touching me and where you're touching me. She was just very clear on it. I will be in control this time. They might have difficulties with breastfeeding. If they had a postpartum hemorrhage, I guarantee you, their hemoglobin dropped down to 5. They aren't going to have enough milk supply for a while. And if they had a very traumatic delivery, they might blame the baby for it. That's hard to say out loud, but they might. And they might not be able to breastfeed because now they feel violated, and that's another violation. These are just stats. 34% reported traumatic birth, 9% actually could be diagnosed with PTSD. 1 in 3 women have been sexually abused, and that means this is a great training when survivors give birth, and it's also a great book just to read. Someone who comes in with previous sexual trauma, and then they have a birth trauma on top of it, well, we're sticking our hands inside them, we're touching their breasts. It's their body remembers, and they start flashing back. They may not even remember their sexual abuse, and they've dissociated and just shut it off, and now it's a boom. I have many stories on that happening. Just can you assume that all parents of NICU babies have PTSD? Can you just assume it until proven otherwise? I find it over and over. Both parents are so anxious. Baby's doing good, they're doing good. Baby crashes, they crash. It's just this roller coaster all the time. It's so scary. And they get ready to plan the first birthday party, and all they do is flash back to that baby's birth. So websites. Maternal mortality, just numbers on 861 in the US in 2020, and actually it increased. Our maternal births increased. And who are our maternal births highest in? Black women, please know that. Maternal near miss, we have a maternal near miss closed Facebook group. So if you know someone who almost died or could still die because of a delivery, please get them into our closed maternal Facebook page, moderated by PSI specialists. Numbers, if you've been under a rock, please come out. The racial and health disparities are obvious. Some states worse than others, and we're worse than others, okay? Our maternal mortality deaths for Black women and racial ethnic disparities are awful in Indiana. And for mortality, also awful in Indiana. That's what we're looking at on Maternal Mortality Review Committee for maternal deaths. And the FEMR people are looking at the infant mortality, but again, higher in Black population. What causes it? People say this to me all the time. Well, what's the reason for that? Just be really comfortable saying racism. Because of racism, we experimented on their bodies without asking. And then we had studies. If you don't know the histories, there's no reason that Black women would trust anybody in the medical field for what we have done in the medical field for years. And weathering racism and the microaggressions, and one Black woman explained it like mosquito bites, just getting bit by a mosquito all the time, every day, all day long. And that's weathering. It just keeps, the rain just pouring on a rock until it changes. They're affected by historical trauma. On and on and on. Okay, I gotta keep moving because I could talk on each one of these subjects forever. Just please wake up about this. And we put out statements from ACOG, from the AAP about racial disparities and the changes they're going to make. And those came out just starting in 2019. So we're pretty behind, right? And I can't show this, but please, this is a Black woman saying this doesn't happen in our This doesn't happen, she said, to people who look like me. So this is a Black woman, one of our PSI members, another one of our videos. That's really good. No, I'll know next time to use my own computer, but I don't know. I gotta figure out why it doesn't work, and then that would do it for me. But it's also on our YouTube channel and all of our PSAs. You'll find it. Look up Lashanta postpartum depression. You know, just Google. 22% have bipolar. Bipolar goes on for years without getting recognized. They come in after they've been cleaning for a week, up, creative, feeling great. And then they come in and after they've crashed and they're depressed. And you don't ask enough questions, you put them on an antidepressant and throw them into mania. Okay, gets overlooked. Many people don't get diagnosed for years. Some people, some women get diagnosed with bipolar disorder for the first time postpartum. Bipolar 1 and bipolar 2, and their bipolar 2 is called soft bipolar. If they go off their meds, the likelihood of relapse during pregnancy and during postpartum, those were with us last night, heard Dr. Arnaudo talk about that, what goes on when they go off their meds and they're doing risk-taking behaviors, they just shouldn't go off their meds. Bipolar people should not go off their meds during pregnancy and postpartum, and there are many meds safe in pregnancy and breastfeeding. Bipolar 2 gets overlooked a lot, not as high. The highs aren't as high, the lows aren't as low. And it looks like treatment-resistant depression. Like you try this, it worked for a while, then it quit working. Somebody tells you they tried 5 different antidepressants, you kind of, anyway. Check this out. We also have a bipolar group led by a therapist that works with bipolar patients and a person with lived experience of bipolar. Psychosis, I pretended I was delighted in order not to make other people alarmed, but I was steadily getting worse, and soon I resented having to change and feed Elizabeth. A deep male voice started to talk to me, coming to me at times I couldn't predict. He told me I was so bad at being a mom that Elizabeth would be better off if I were dead. The voice told me that Elizabeth was sent by the devil. Then I began to fantasize about hurting her. I knew it was time to seek help. Do you hear that? It's not what you think about psychosis, is it? She said, I knew it was time to seek help. That's when we miss them. It waxes and wanes and we miss them. And then they have a psychotic break and do what the voice is telling them. But they might have sought help already and it just wasn't recognized. Psychosis waxes and wanes. I'm fine right now, but 2 hours from now, I'm back into a psychotic episode. I'm thinking you're poisoning me. I think I'm on the same level as God and angels. I say things that make you wonder, oh, she just needs some sleep. Oh, this is embarrassing. One husband said in front of me to her, quit saying these things. Why are you saying these things? You sound crazy. Poor thing. She's out of touch with reality. Andrea Yates was convicted for murder of her 5 children, and our lovely George Parham turned that over in 2006 for not guilty for reason of insanity, but we still have women in prison. 1 to 2 in 1,000, 5% die by suicide, 4.5% committed infanticide. So onsets, previous episodes, risk factors, usually within 2 weeks, but can happen later on, up to 6 months even. So I've seen it a lot early on, I've seen it a lot later on. I've seen a lot of it. So, you know, call people that have seen a lot of psychosis and know how to help you with it. Thought broadcasting, tangential, rambling. One woman said to me, oh, trying to fill out just a simple Edinburgh postnatal depression scale. Well, now, this one right here, what do you think this means? She just wanted to have a conversation about everything. And I finally just said, you know what, let's just talk. She could not fill it out. She was so tangential, she was fun. But she was tangential, it's all get out. I always think in my head, I just can't wait to meet them later on because they're going to be back to themselves. There's hope. You imagine getting to work in a field where you have people come to you and you get to help them get better? I mean, really, I just couldn't be more blessed, could I, to be working in this for all these years. Psychosis, the number one is you got to assume it's bipolar disorder until proven otherwise. It's like 86% are going to have bipolar disorder. Didn't already know it, what they weren't treated, going untreated, or they're diagnosed for the first time. And that's a shock. Not only did they have psychosis, but now they get told you got bipolar disorder. Maybe for life. We don't know. We're doing studies on that. Here's a great resource for that. You have these handouts, black and white handouts. Mass General is the place to look for information on psychosis. Send all your patients there to be studied. All my former clients with psychosis are working with Mass General. They give saliva and then they go out there and get scans, and they all are willing to do it because you want to find out, can we do something about this? We have several psychosis coordinators, and we have, yes, we do, perinatal and postpartum psychosis support groups. They don't come when they're in the stage where they just, well, they can when they get out, but they're still not thinking real good when they first get out of an inpatient facility, but they can come to group. And then we have group for families who were touched by psychosis. We have a great video called Healthy Mom, Happy Family, which I am in, and show that in childbirth ed class, show it rolling in your offices, show it to your clients after an intake or anytime. It is not depressing. It's to have 4 women telling their stories. And many times what you'll find is your clients are like, ooh, I'm feeling that, or wow, I got a lot of risk factors I should watch for this. Okay, dads. 1 in 10 dads. We have a chat for dads and we have dad support groups. So make sure that you are asking partners, same-sex couples, the partner may also be suffering from a perinatal mood disorder. So ask the questions. Dads look different. We studied 5,000 men in 2 different studies, 5,000 each time. We found out 1 in 10 dads also get postpartum depression. What's the #1 risk factor? That is female spouse has postpartum depression. Now we got 2 depressed, anxious parents with a baby. We got to do something. Wherever we did studies around the world, it's right around that 10%. So this is really common. And our Dr. Daniel Singley, who does our chat with the dads, thinks it's higher. He just thinks a lot of men don't admit it. And so he thinks even with our studies, it's still a lot. And again, this one you can just go to YouTube all on your own, put in David Levine postpartum depression for fathers or something like that. And it pops right up. It's a 5-minute video. It's him telling his story of having postpartum depression. What looks different? They go to their man cave. They play video games. They come home later and later from work. They're angry. They're irritable. They feel burdened or trapped. Finances feel responsible all to them. They're overwhelmed. And guess what? Now it's all about the baby, then the birthing person, postpartum person, and the partner is thrown out of the picture. They miss sex and they miss their partner. And nobody pays attention to them. Honestly, you know we don't. And we act like they're idiots on top of it. Single mothers, even worse. They're afraid to tell you anything's going on that you're going to take their baby away. Single fathers, high mortality rate due to binge drinking, hypertension, and risk-taking behaviors. LGBTQ+, very few studies. We don't know much. Okay, so I just have a few slides, but we don't know much. We don't even know statistics. In the UK, they found that they identified lesbian couples are one of the fastest growing couples with fertility, right? Being in there with that. So you got your fertility roller coaster with them. Pregnant trans men are also becoming a growing population. I'm not going all over all these. 2 gay men adopting baby or using a surrogate. We don't have any studies at all. And I've never gotten a call from gay men after having a baby. Or a friend of mine's son and his husband are adopting right now. And I just think, oh, of course, overnight they're going to lose all their freedom, all control their schedule, and not know what they're doing. But we don't have much for them, do we? Or some people who are frowning on, what are they doing adopting the baby? Non-gestational parents, make sure you're checking on them. And we now have a 6-hour advanced training on maternal perinatal mental health. Check our website, go to professionals, trainings, and go look and see all of the trainings we have. You're going to be wowed Identifying, let's look at screening. What do I got? I'm just gonna do this. I'm gonna do it. I'm gonna make it right on time. Planning ahead. I teach a 4th trimester class. I told you this is where we plan ahead. They must know that they're gonna have to get rest, eat, sleep, go for walks, ask for help, receive accurate information. What does it mean that look like? Create a coping and support plan and come on, if you're a labor and delivery nurse, quit rolling your eyes at birth plans, okay? Quit it. Let them have the birth plans. Let's not make fun of them and talk about them. Oh, there it comes. We're gonna have a C-section now. You know you said it. I had a plan, but these were all my coworkers, so I came in with the birth plan because I knew they all made fun of birth plan. So I came in with them and said, at transition, give my husband an enema. My mother shows up, and then I have a whole bunch of stuff with my mother. She was getting an enema too. She had a lot of other things going on with her. They laugh so hard. Yeah, I had a really good one. Make sure that you go over postpartum planning with your clients. Really, how are we gonna do it? You think you don't need this, but you do need it, okay? So let's do some postpartum planning. Who is gonna help? So that's the stuff. Sleep, they don't know how to sleep. So make sure we go over sleeping. I don't do these things. I'm still on my phone a second until I turn it off. Because now I'm hooked on everything. I hardly read a book anymore. I read my phone. What's that about? And then you find an article, and then that leads you to another article, and then that. And next thing you know, you've gone down the rabbit hole of how many articles. And you're like, I really want to read that book next to my bed, but when am I going to do that? So whatever, and just ask me. I'm not big about posting, but I repost. I don't look at Twitter hardly at all anymore because I'm hooked on TikTok now. Anybody, the nurses in here, come to our Indiana State A1 meeting this year in Noblesville, I think it's going to be. Anybody watch TikTok? Watch Jen Hamilton, labor and delivery nurse? Okay, she's going to be there to speak. So just saying, I love Jen with her chickens inside her house and all that. Anyway, screening. If you don't watch TikTok, you don't get it, but I hate to even admit that, but I really love TikTok. You can't tell by looking. You cannot tell by looking if someone's depressed or anxious. You have to ask, how are you doing? Does not get it. How are you doing emotionally? How are you really feeling? That gets the tears. That gets the, well, not so good. Don't give a screener, don't give a screening tool and score it and put it in the electronic medical record and not educate her and not mention it. Do you know how many clients have told me that, yeah, I took it every single time I went in. It was high every time and no one ever mentioned it. Don't let them leave without looking at what they said about suicide. Don't do it. We know who's at risk and how to screen, and we have treatment methods. So we should be doing this. And all of our organizations say we should be, but then we're not. Takes more time. We don't get paid for it. I don't know what to do if she scores positive. Well, when you leave here today, you're going to know what to do when she scores positive. So recommendations from everybody, but listen to what right here, we're going to pick on the OBGYNs. There's a public perception that OBGYNs carry the most responsibility in screening. However, OBGYNs didn't view themselves as the most responsible. And later we pick on the pediatricians. They say we should be screening, but less than half of them do. Barriers, perception, it may be time consuming. Honestly, sometimes it's like, oh, I can't have her fall apart. I only have 15 minutes and I don't know what to do with her anyway. Unsure about treatment, so we need to know that everybody knows where to send them. We reduce the severity and the longevity when we get them treatment. Who should be screening? That finger pointing at you. Every one of them should be screening. What's the standard of care? Like I said, American Academy of Pediatrics, ACOG, and Family Practice all say screen. Here's our recommendations for PSI. You can look at this later. We have this amazing discussion tool if you just want to print it off and use it. And wherever you have the handouts, I've got some out there on the table. Happy for somebody to set it all up. You probably help too. Thank you, thank you. So They're out there in both English and Spanish. At the bottom of this, it gives some risk factors and it gives some like maybe some of the symptoms they have. And at the bottom, it's got our helpline, and it's got how to hook up to our support groups, and then it's got our psychiatric consult line on there. So give them, offer them privacy. We are screening everyone. Don't make them think that they didn't look good today and that's why you're screening them. We screen everybody because 1 in 5 to 7 women get this. The most well-researched are the Edinburgh Postnatal Depression Scale and the PHQ-9. So EPDS is probably the most commonly used, although PHQ-9 is right behind it. 10 questions, last question, the thought of harming myself has occurred to me. They might say I used to be a cutter and I'm afraid I'm gonna cut again. They might say I tried to kill myself when I was 14 years old. Well, the screen says in the past 7 days. So you have to say, so you always have to go back and ask more questions. There is a severity ranges. It's common sense to me. The higher they score, the more depressed they are or anxious that they are. PHQ-9, 9 questions. Their question is, suicide question is pretty in your face, thoughts that you would be better off dead or hurting yourself in some way. Now that one is over the last 2 weeks, not over the last 7 days, and their answers are a little different. And it looks more probably at depression than it does at anxiety. There's a short version of the PHQ. There's a 4, and there's shortened versions, PHQ-2 and the EPDS-2. Great tools, just remember they're not asking about suicide, okay? So be sure you do that. There's also a PDSS by Cheryl Beck. Downside, you can copy the EPDS and the PHQ-9 for free as long as you put the authors on. For Cheryl Beck, you have to pay for it. So that's why it's not used as much. We also have a screening tool for bipolar called the MDQ. Screening is not treatment. Suicide, there's the numbers for it. You know I'm almost done, so I have to go fast now. We aren't going to talk about suicide, but you got the slides. Here's the biggie I want you to have before we leave, so you know your own diagnosis of what's going on. Who gets this and why? Previous history of depression, anxiety, OCD, bipolar, alcoholism, substance use, suicide, intrusive thoughts, any history, family or personal, you are at risk. You explain to your patient, here's why you have it. You didn't do something wrong, you're not weak. This is, you are not to blame. Maybe it runs in your family to have perinatal mood disorder. You were a moody teenager, you had bad PMS, moody, irritable before your periods, and hormonal birth control makes you mean and moody. You give them the depot shot and they're mean for 3 months. Of course they don't want to take it again. They were mean, they yelled at everybody and they knew they were acting crazy, but they couldn't stop it. Thyroid imbalance, decreased fertility, fertility roller coaster, diabetes. These are facts. These are risk factors. Did you get a choice? No. Inadequate social support, interpersonal violence, financial stress, recent loss or move. Their dad died, their family pet died, they moved across country. Military families, teen parents, parents of multiples and single parents, even higher risk. Racism, complications in pregnancy, birth, or breastfeeding, exacerbating factors. Teenager or 40 years old or more. Seasonal affective disorders, perfectionism, which I already mentioned, pain, lack of sleep, abruptly stopping breastfeeding, childcare stress, relationship stress, previous losses of any kind, perinatal losses, miscarriage, elective abortion, termination for medical reasons, childhood sexual abuse, culture shock, career versus motherhood, unresolved grief with your mother. Your mother died, your mother's in another country, you haven't spoken in 3 years, you scream at each other all the time. You might be an adoptee and you start to think about your birth mother. So mother issues come up. Returning to work outside the home after you have a baby is a shock. You come home to your second job. Rule out other causes. Make sure you see everything else that's going on. They are not saying I have postpartum depression. They're saying something's not right. Here's the stats for how often someone has the things I mentioned earlier. And yet 21% get a perinatal mood disorder. We screen everybody for hypertension, diabetes, and preeclampsia. Okay, there's where we have the pediatrician. There's my hospital algorithm. I know I know my time's up, but let me finish. I want to show you resources and then I'm done. We get better by medical evaluation, counseling, and social support. They need the social support. They will say, I couldn't live without it. But they might need meds and they might need a therapist. And they might need all three of those. They certainly need new parent classes because they don't know what we're doing. You're not alone. You're not to blame. And with help, you will be well. They have to know that. Getting treatment, all these things. I'm not going over complementary or alternative. Some of your patients are doing placenta encapsulation. Just ask them about it. I can talk about that later, but I want to treat them during pregnancy or they're treating themselves, okay? Bad outcomes if we're not treating them in pregnancy. They need to stay on meds, they need to stay on meds. Breastfeeding, we just want to give them the facts. If they want to breastfeed, please let's help them. If they want to stop, bless them and let them stop. I could talk lots more about breastfeeding. I'm sorry that I'm out of time. Just pretty much know if they wanted to breastfeed, they didn't get to, they are grieving the loss of the breastfeeding and they're a mess, okay? So understand that. So lots of resources for breastfeeding. Here's some websites and handouts and all of that. I want you to know, CHAMP, our state, you got that for handouts, a line that prescribers can call and ask. Our support groups, we have a handout for that. Join, if you're a mental health professional, join these two Facebook groups and you're gonna learn lots of fun stuff. Other organizations, please send to our psychiatric consult line. It's also available with a reproductive psychiatrist. Make an appointment if you're a prescriber, only if you're a prescriber, okay? Get help, our helpline, our hotline. Make sure you're passing these out to your clients. We have a Perinatal Mental Health Alliance for people of color. Join that if you're a person of color. We have support coordinators in every state. Jennifer's one right here in the state of Indiana. Woo! She keeps resources and she'll tell you what's going on in her area here. She knows. Specialized coordinators, you can call them. We have coordinators in over 40 countries. We have chapters in every state. We do a Climb Out of the Darkness every year. We have a closed Facebook group for your clients. They can get on and talk to other people. It's moderated by PSI. All kinds of support groups, virtual support groups. Go look and see. Chat with an expert they can call. Smart Patients Forum. Please be looking at these handouts you get on what you can actually give to your clients. You say, we don't have anything. You got lots of things right here. We have peer mentors. They can get hooked up with a peer mentor. Discussion tool. We have trainings. Make sure you're looking at our trainings. We have posters, brochures, videos in English and Spanish. There's our social media, all kinds of Spanish. There's our videos, our bookstore. Training. Get more training if you want to be in this field. We're going to be in Kansas City the last of June, 1st of July for our annual conference. Volunteer with us, join us. We have virtual rounds from Mass General Hospital every Wednesday. Certification in perinatal mental health in case you want to be certified. And that's it. How far did I do? How bad did I do? 5 minutes over. And I didn't even cover much on breastfeeding. So sorry. That's it. I felt like there was something else. Yeah.
I just have a really quick question. The
Yeah.
statistics and whatnot, are those all mostly based off of first pregnancy or first?
No. Any. There's really no stats on most people get it with the first one, or most people. I saw a woman once who didn't get postpartum depression until her 5th.
Just because it talks a lot about with that lifestyle change.
That is a biggie because that's the transition to parenthood. But someone lives through the transition of parenthood and they get postpartum depression on their 5th. And what you want to look at is what risk factors happened this time around. And you might find her dad died, her husband had something happen. I mean, you'll see the or listen, she's 42 years old and she's now in perimenopause mixed up with hormones that happen with postpartum pregnancy. So all of a sudden you'll see when it happens in a subsequent pregnancy that there's something that never happened before. But also when someone gets a perinatal mood disorder, they're 50% chance of getting it again. When they get it a second time, there's 75% chance. Just give it up. Like somebody just said to me today, I did everything right and I still got it. Sorry. Any other questions?
I was just curious about, you said there's like no statistics on getting in adoption and kind of that process, like, that's just stigma because they've done the adoption, so they don't want to call in. I just wondered.
I think that's some of it, but it's the researchers, oh, mine went dead too. Everybody went dead. Oh, you turned it back on and I turned it back. I think it's just when researchers say, I want to research something, it's just something they're not researching. I'm sure I'm going to find a little bit on it. But I mean, trans men, all we know is generally with trans men, they have a higher suicide rate and stigma goes with that. But is somebody really researching, do they get a perinatal mood disorder? Not right now. So some of it's stigma. You can't even find healthcare sometimes, somebody that will. I mean, I know a lesbian woman who said she overheard the nurse practitioner in the next room say, I'm not going to see her. I don't believe in lesbians having two women having a baby. I just refuse to see her. She overheard her saying that. So she was like, I love my OB, but I'm not going back to that office now. And I was like, oh, really? Your OB is really great. We just happen to have a nurse practitioner in there. But how about it? So, yeah.
They probably fight so hard to get the adoption approved because of the stigmas.
Yes.
They're not gonna report that there's problems afterwards because fear, there'd be a lot of fear.
It's with any adoption, anybody that has adopted is afraid to say, like, think about even infertility, and you've been trying to get pregnant for like 10 years, you finally have a baby, you think this is gonna solve all of it, we're gonna all be happy. And she says overnight, I lost all my freedom control. I wish I hadn't done this. This is a huge mistake. Who's gonna say that to you? No one. What? We've been trying to have a baby for 10 years and you're not happy? Adoptive parents, you're supposed to be happy. You chose this. But you know what? They came to you with probably fertility roller coaster, lots of losses, lots of IVS, spending lots of money, and now spending even more money to adopt and have to have a home study. You're not allowed to say you're not happy. And international adoptions, those babies come over at like 7 months. They've been drinking another formula, hearing another language on another time zone, and we think they're gonna go, Mama. And instead they scream in your face for like weeks because you're a stranger. Yeah. Yeah.
I just, so I was wondering, is there a difference between like intrusive thoughts and dreams? Like I have a client who has dreams about getting possessed and harming baby or something like that. So are those separate or do they kind of?
It kind of goes together. She's asking about dreams of harming the baby or becoming possessed. It's in her head, and I would treat that just like an intrusive thought. Myself, we have lots of weird dreams when we're pregnant. About something happening, and we just do, it's part of it. And some antidepressants cause people to have nightmares also, it's just fact. And there are meds, there's one med that I know of that you can give for nightmares, but I would talk through it with that was just a dream. Facts are that you're not possessed, and talk, you know. Yeah.
Birdie, thank you so much. We
You're
actually
welcome.
have to
I
move
know.
on to the next group. So thank you so
And
much.
you got- right.
But let's just take 5 minutes and then we're gonna have back.
With our next segment, the IPV Accuracy and Lived Experience. Some of you might not necessarily know me. My name is Patty Miller. I'm the mental health social worker at Beacon Health Hospital. I work with perinatal population and I have for 10+ years. I've been doing social work for 20 years now. I have the pleasure today of introducing Jessica Richmond Castello. She is a domestic violence and sexual assault advocate. Her passion is the community is rooted in empowerment and education for everyone around her. She is the director of victim services with the Family Justice Center of St. Joseph County and has over 9 years of experience in serving survivors of domestic and family violence, sexual assault, and stalking. Ms. Richmond Castello has specialized training in areas of crisis intervention, protective orders, strangulation, and danger assessment. Her work hinges on victim safety, offender accountability, and instilling hope for the future of her clients. I also will be introducing Kelli Brien, she is certified doula, childbirth educator, lactation specialist. She created the Speak Life Doula program and authored the Safety Pen Grant submission that garnered multiple awards from the Indiana State Department of Health. Kelli founded In Full Bloom Maternity Service, LLC, Mahogany Maternity, a 501c3, has served in hospitals, home births, and birth centers for over 14 years, and established the 32nd Milk Bank Depot in Indiana. She serves on the St. Joseph County Fetal Infant Mortality Review Team, the Indiana State Department of Health Maternal Mortality Review Team, the Board of Mental Health Awareness in Michiana, and chairs the Birth Equity Subcommittee for DONA International, and serves as the Director of Diversity, Equity, and Inclusion. She co-founded Birth Equity and Justice St. Joe County, and has testified at the Indiana State House and House and Senate chambers in support of Senate Bill 416, which passed to be signed by Governor Eric Holcomb. Now, mouthful. So these two lovely ladies are going to get us started. Jessica will get us started here. We'll save questions for both of them at the end.
Okay. So a couple of housekeeping items. I have been working in domestic violence work, and this is a tough and a heavy subject matter. I totally get that. So please know your boundaries, know when you might need to step out, and there will be no offense taken by me. So my goal for today is, I have a short amount of time, so I'm gonna fly through some information, but I want this to be a leaping point, and I want to have this create more conversations down the road. I'm extremely passionate about the intersectionality between maternal mental health and domestic and sexual violence. And I'm gonna explain a little bit more as to why. But I was asked last year to speak at the Labor of Love Summit, and I put this graphic together. And it's become a graphic that is extremely powerful and extremely powerful in my work, because these amazing humans lost their lives in domestic violence, but they're all moms. So I want that to resonate in the conversation that we're going to have today. These are all moms from our community that have lost their lives at the hands of their intimate partners. When I first started in this work, I found a statistic that was 47% of women that experience domestic violence and then experience homicide by their intimate partner had engaged with a medical provider in the year prior to their homicide. And for whatever reason, in the 10 plus years that I've been doing this, that has stuck with me. We have a point in time, people might not ever get to my doors as a service provider, as a specific housed service provider for domestic violence survivors. They might never make it to me. And some of these lovely, amazing moms didn't. But they've made it to many of the people that sit in these rooms. And having that engagement and that ability to have those tough conversations is so mission critical. So last things as it pertains to housekeeping, I do tend to speak in she victim, he offender, because that's the vast majority of the research that's done in our country. I do know, and I want it to be very clear, that domestic violence knows no gender, socioeconomic bounds, anything along that, but the vast majority of our research is she victim, he offender. And so I like to talk about my own experience with this question of, are you safe at home? And it requires a little bit of background information about me. I am a rape survivor. I was raped at the age of 17. And that really affected me greatly. And I struggled with an eating disorder. I struggled really, really bad with an eating disorder throughout my college years. And then when I became pregnant with my first child, I was diagnosed with a rare, it's called pseudotumor cerebri. Basically, my body wasn't absorbing the spinal fluid. So I was having tests done regularly because, of course, my greatest fear was to go blind. And what's the one thing that could happen in the process of having my baby is that my pressure could get too high and I could end up going blind. So I struggled, and I hadn't ever disclosed the fact that I was a rape survivor to my OBGYN. And it wasn't until I got to about the 6th, 7th month mark where I was really struggling with my eating disorder. And I finally have made this really beautiful connection with my nurse that was with my OBGYN. And I told her, I was like, I need to do blind weigh-ins. You'll never guess what that OBGYN did. He made fun of me for it. He made it this big thing of like, oh, it's no big deal. Oh, it's not a big deal that you, but then he would sit there and he would say to me, well, we need to trim down the weight, like you're gaining too much weight. And if you're worried about the potential for blindness, like we've really got to figure this out. And I'm like, okay, hand me the magic plan for that because I don't know. Mind you, then right before, because I needed to go into labor because my pressure was getting so high, he stripped my memories without asking me or even telling me. It wasn't until after the fact that he told me what he had done. So that all is like the right up until my experience with this story. So that's the background. So the night that I go into triage, I had gone into triage several times. This is my first baby. I didn't know what was going on with my body. I had all these pressure things. I was having terrible migraines. I was confused. I was young. I'm still but I go into triage and I have this amazing nurse. But mind you, this nurse, I'm in a bed, like as triage is, and she's standing at her computer doing her thing, the nausea, diarrhea, vomiting, blah, blah, blah. And then she asks me the "Are you safe at home?" question. And mind you, I'm in my position that I am currently as that question is being asked to me. My husband sitting next to me at my bedside, he starts laughing. And this poor woman turned to me, white as a ghost, and was like, "Why are you laughing?" And my husband stands up, walks out of the room, is like, "I'm gonna get a cup of coffee, you're in for it, like have a good time." So he leaves the room. We then were able to have a really amazing conversation, and it really pushed me to want to be in this arena, having these types of conversations, because as people working with new moms or pregnant individuals, you have the ability to isolate them away from their potential offender, like at the drop of a hat, like follow my butt into the bathroom and ask me the question and say, "It's okay, like just nod at me or blink once if you're not safe." And we're not gonna have this conversation right now, but at a safer later time, we will have this conversation and we'll be able to discuss what next steps are possible. Or make up a test, make up an exam, make up an excuse to get me out of that room, or make up an excuse for that person to be removed from the room. That can be trickier than one would think, especially when they aren't safe, because often you'll see that kind of hounding and that desire to keep a finger on the pulse of what's actually going on. So that really is the goal of our conversation today, is to remember that question can save lives. The "Are you safe at home?" question can save lives. And specifically in our community, we have the Family Justice Center, which I love with every fiber of my being. And we have the ability to be a supportive service alongside you. Something that I am very passionate about is the fact that we are happy to come to your facilities. I've gone to Jen Carter's facility and met with a survivor when her offender was sitting out in the waiting room. And it was the only time, because there was active stalking that was going on. There were different pieces that didn't allow that survivor to come to our location and receive services directly from us. That is our job. That is our burden to bear. Your burden is to get the question answered and get a clear, honest answer. And even if that means having a survivor look at you and say, "Yeah, I'm safe at home," but her face tells you something completely different, or the mannerisms between the two tells you something completely different. Don't just take it on face value. It goes very much back to Birdie and having that conversation of you have to keep asking the question. You have to keep digging deeper if your gut and your instincts are telling you there's something else going on here. So you have your definition of domestic violence. And domestic violence and domestic abuse can be so many different things, especially coming out of COVID. We are seeing at the Family Justice Center, we're seeing so much financial abuse. Financial abuse is something that has become a major issue because we had so many cases and so many clients and survivors that had to reintegrate into households that might not have been at pre-COVID. They have been able to separate
and live financially stable apart. But then when you have kids and you have schools that aren't open and all of those pieces, and or your finances just aren't the same, there's loss of a job, you see that reintegration within homes. And we've seen quite a bit of financial abuse in the past several months. So keeping in mind, especially for our mamas, you have that fear of harm and fear of death. And I'll be honest, as an advocate, I am positioned to have some of the toughest conversations with so many of our clients to help them understand, I hate to have this conversation, but what happens when he kills you? What happens to the kids? And sometimes it's that wake up call of like, oh, she went there. Like, but we have to go there. We have to have that conversation of, I know and I understand that there's fear of harm and you're scared that bad things are gonna happen, or that you're protecting the kids from the violence or whatever their train of thought might be. But what happens when it escalates to a point that there's no turning back? And then that offender gets and has the children after he's killed you. I've seen major incidences occur where offender ends up with custody of the children. We can't be naive to our systems in the way that they work. My job is to help clients navigate those systems in the best ways possible, but I can't sit there and tell them that it's gonna be magic fairy unicorns that are gonna help them if they don't take some control that they can in a safe way and make strategic decisions to work with us and help move forward in that process. Acute injury and long-term issues, I will say it, and I will say it and say it and say it. And I smile because Nancy Grant, the coordinator of our forensic department, is sitting in the room. But strangulation is such an issue, and we need our survivors to be going to St. Joe Regional Medical Center and getting a full forensic exam done, because they are the leading partners in our community. They are the ones that are doing the work and getting survivors the information, and we work very closely with them. We also work really closely with Memorial in any capacity that we can, but they have a full forensic unit, and they do the best at educating our survivors on the next steps and the different pieces of effects that can occur. I've had 2 or 3 now victims that have had strokes post-strangulation incident. We've had many survivors that are pregnant while they're strangled, or they're pregnant and then they're strangled on top of that. And that is a big issue. The struggle becomes there's issues with criminal elements, but spontaneous miscarriages after a strangulation incident, I've seen it. It's really hard for survivors to cope with that. And then you have gaslighting that offenders are like, well, I didn't do that. There's no way to prove that. There's no way that incident occurred your body can handle it, or whatever that their line is going to be. We need to be having those strategic conversations with our survivors. Loss of job, financial, legal issues, homelessness, and then the added elements of the Department of Child Services. DCS is terrifying. Like, I'm a mom of 3 tiny humans that I love. While they're challenging most days, I love them beyond life itself. But DCS is still scary to me, even though I know that I'm a good parent. And I do everything that I can to provide and support for them. So survivors that are put in these situations and they've heard these phrases of like, well, I'll take the kids from you, or I'll get custody of them because maybe you have postpartum depression. I had a survivor a couple months back, it was late last year. Her offender kept telling her that she had postpartum depression, and that's why she would go, like, that's why she was crazy and she would pick fights, and but she had gone to 3 different clinicians, and the clinicians are like, you don't have postpartum depression. But her offender kept telling her, you have to get a diagnosis of postpartum depression, because that's what he needed to justify his abuse in the situation. And so really helping the survivor understand that, okay, 3 clinicians have told you that, like, how do you feel about this? How do you feel about these diagnoses and the fact that you're not being diagnosed with postpartum depression? And maybe it is just the fact that there's domestic violence going on in this relationship. Are you ready? High risk factors in domestic violence cases. This is Dr. Jacqueline Campbell. Strangulation. And I say strangulation because I want that word to come to mind. but helping survivors identify what strangulation actually is very important. Survivors don't necessarily think strangulation, oh, that's happened to me. Sometimes they'll identify it as choking. Well, all of us know that choking is allowing something in your throat, but it's pressure applied to the point at which it's hard to breathe. Suffocation, you see a lot of suffocation. You see a lot of just compressing the torso. Anybody that's in this room that's been pregnant knows that as you progress in your pregnancy, it gets harder to breathe. It really does. And so that lowers the pressure that it requires to make it even harder to breathe, because there's not as much air that's being or oxygenating you. Possession of a firearm. This is something that has become a bigger issue in our community specifically, especially with COVID. So at the beginning of COVID, we realized that we were starting to see a pretty intense spike in domestic violence here in St. Joseph County. And the biggest indicator that I noticed and what we started tracking was the use of a deadly weapon. And firearms were the leading element in that. Our community does what's called the DAIL, which is the Danger Assessment for Law Enforcement, which is a shortened version of these high-risk factors. That assessment is done on scene. If a survivor scores 7 or above, or the officer thinks that maybe there was not some full truths being told, or there wasn't the ability to separate them enough. And so then they have the ability to override that. All domestic violence related police reports come into my email inbox every morning. I then review them and we assign them out to advocacy staff for them to do outreach and try to engage survivors and services. Because it's not just good enough for them to know that services are an option. We have to give them that touch point, because we know statistically that we can reduce the number of times that it takes for them to leave that relationship just by them knowing that services exist. And our community is positioned, and I will keep saying it, our Family Justice Center is the only one in the Midwest. The closest to us is Milwaukee. It's a beautiful center, but Indiana doesn't even have other family justice centers. We have other shelters and other agencies, but our SJC, which I'll talk a little bit more about in a second, has the ability to help coordinate all of these services and all of these pieces for survivors that make it so hard to leave and to stay gone. So FJCs. FJC is a model and it's an umbrella. We have our Child Advocacy Center in our building, which is the Casey Center that some of you might know. They do all of those forensic interviews for kiddos that have either witnessed or experienced domestic violence, sexual violence, abuse, or neglect. Then we have our law enforcement partners, prosecutor's office, adult protective services, and then our social service end of the arena. Our biggest piece is the safety planning. One of the most important things to know when you're interfacing with survivors as you're in your field is they need a safety plan. They need to have information and education on how to keep themselves safe in their situation, because as much as we would like them to leave and never go back, the reality of that is they will. And so what tools can we give them in that strategy of their safety plan to help keep them safe long term, and or then be able to build their next steps and exit that abusive relationship. So safety planning, danger assessment, we use this as a tool. There's kind of 2 camps when it comes to the danger assessment. And one sits on the side of the survivor knows best, and the survivor about 50% of the time can tell how much danger they're in. And the other is that the survivor doesn't know. I tend to kind of sit in the middle, and I want to use this tool to help survivors help educate survivors on what risk and what lethality is in their situation. We want to know if there's ever been battery while pregnant. We want to know if there's stalking that's happening. We want to know if there's forced sex. And we want to know if there's strangulations and firearms and an increase in severity or frequency over the past year. We need to know those elements so that we can filter them in as we're making safe next steps for their life. Protective orders. I could do an all-day training on protective orders. They are a tool in survivors' toolkits. Often law enforcement will tell them, go get a protective order. Protective orders are complicated documents. They are It's a pains and penalties of perjury, it's a court document, and there's pieces that survivors don't always know going into it because they've had a lot that has likely happened to them in the last 24, 48, and potentially years prior with that offender. Many people don't know that the other person gets a copy of it. That can increase lethality. We don't want many people don't know that that's actually a public record document. Now, the court does their darndest to keep that under wraps and not, but if for some reason the media were to file a request, they could have to relinquish that. And we want people to know, be educated and make the best next steps decisions. We also have a protective order attorney on site, case management. There's so many pieces to survivors' situations. Sometimes they have DCS involvement where there's an open chins, which is a child in need of services case. There might be a divorce pending. There might be a criminal case. There might be a civil protective order. Yeah, some of those are going to be integrated together. But I've had survivors that will literally text me first thing in the morning and go, I don't know what courthouse to be at. I know I have a hearing at 9 a.m., but I don't know what courthouse, and I don't even know what case it involves. And so that is our role. Our role is to take that burden off of them and help them understand and navigate the different pieces of the system. We have a special populations advocate. She is Spanish speaking and focused on our special populations. A licensed clinical social worker, so she meets one-on-one and she does specific group therapy, both empowerment group and a closed sexual assault group as well. Emergency food pantry, resource room, play space, 911 cell phones, locking mechanisms. Sometimes we file a protective order and they get use and possession of the home, but they don't have the means or ability to change locks immediately, making sure that we can create some safety for that survivor in the next steps. SOS. SOS is your greatest asset in this work. I put a bunch of materials right outside the auditorium on the tables. SOS is on every piece of that. It is our 24-hour crisis line. It's been in the community for 50 years. And that is community partners, survivors. You have access to an advocate 24/7 in our community. You can call that crisis line and ask questions, have safety planning conversations. We see our most prevalent is survivors reaching out. RAIN routes people that call from our area to our crisis line if they haven't called it directly. And then we do medical accompaniment to both of the local hospitals, both St. Joe and Memorial. And our role within the hospital is very specific. Our role is to focus on survivor support. I was in the hospital on Valentine's Day, actually this year, and I was on call and a survivor, my only role and the one thing that made me so glad I was there, she had been hit so hard that he severed her trachea. And she was laying in that bed and she was petrified because you had just a cluster of doctors around her. She had been through something so unbelievably traumatic and nobody was taking just a split second to tell her it's okay to be scared. It's okay to be absolutely terrified in this moment, and you are putting a lot of trust in these humans around you, and they're telling you, I'm gonna have to put you to sleep, and I'm gonna have to put a tube down your throat, and I'm gonna have to breathe for you for a while so that your body can heal. And that's a lot for a human. That's a lot for a human, let alone a human that's been through so much. And her biggest fear was, what about my kids? What about my kids? And so stepping back and saying, it's okay to be scared. I promise we will figure out these next steps. It's okay. And amazingly, she's doing well and making progress, but that's the goal. That is the goal of the advocate is to be that emotional support and help navigate those systems. And referrals really focused, and then specialized training. We do risk reduction and as much prevention education training in the school corporations as humanly possible. And then specialized trainings like this, where we're working with other community partners to know and understand why it is so important to refer into the Family Justice Center. All of our services are 100% free. I always forget to tell people this. We have a clinician, we have a protective order attorney. No one ever receives any sort of bill or anything. We are community supported and also VOCA and federally supported through grants. And so these are our contact information. Okay.
Thank you so much. I'm gonna take a moment to breathe. A lot of information, a lot of thoughts, a lot of relating, a lot of fear, a lot of trauma, a lot of confusion, a lot of grief, a lot of memories. And it's time to talk about somebody who's probably a seat or two away. Somebody that sits at the table across from you, somebody that you talk to on the phone today, somebody that you will eat lunch with tomorrow. I'm also talking about myself. I'm talking about someone who grew up in a bedroom where a bucket full of water was placed outside the door. So two little children can open that door and see their mother being beaten. I'm talking about waking up to the sound of your mother being beaten. Having to run outside in your underwear and a t-shirt to the neighbor's house and ask the neighbors to please call the cops to get the fire from your mother. I'm talking about someone who found so much to explain to her when she was growing. I'm talking about somebody that you will come across all the time. Very professional, very happy, very chipper, a hard worker, an overachiever or an underachiever who lives this life and who has this veil over her face every single day. And you know her, and you love her, and you pass her, and you hate her, and you experience her, and you have no idea who she is. But she's sitting right next to you, or maybe she's here. I stand before you, a liberated woman. And I say that trembling. I say that trembling because most mornings I wake up happy and excited, full of joy, and the phone rings, and his name comes up. And I remember, this can be another call. Quite often, the elephant in the room is not the woman you see. It's the woman that you experience when he has told her, when you come home, this is happening. Or he's come to the office to bring her flowers. And everybody's like, oh my God, he's great. You like her best. Well, we're jealous. We know what's gonna happen tonight. And she knows those flowers mean he's been home waiting. The kids aren't gonna be there. And you know that he took your phone. And you know that you have to be at work tomorrow and put the face on for everybody that you pass. And you're gonna have to perform and make sure that everybody in your office is good, because you don't want to trigger any alarms, because it's gonna make it worse. It's not gonna be feed, find, or heal your children when this does to you. I share this with you because he's everywhere. He's everywhere. Her children are everywhere. And they may go on to repeat it. And thank you, Jessica, so much for your staff. And for what you do. Because I sat next to Jessica's staff at my court date. And it took me 8 times to go to the bathroom and calm myself down to walk into a child support. 8 times. I had eaten days, but I went to the bathroom 8 times before I walked in the courtroom. Sitting across from me, staring at me. And there are words that they said that you don't know that they're saying that tell her what I'm going to do to her. There's a trigger word that they'll use to make her straighten up and fly right. there are different things that he does to let her know, I got you. And you wonder why she's moody, why her production is extremely high, she's our best artist worker, or why she's just always she's aloof, or she's bougie, or she's funny acting, or she's strange, or whatever the case may be. But I say all that to say, not only what you don't know in her term, right? So you may not know that if she stays over 5 minutes, because we just gotta get this last bit done. You have no idea what that can be for her in light of getting home, in light of eternity. Like that was just 5 minutes, right? That was, I need to go to work. I'm gonna pay for the next 2 months. That was my kids are gonna pay until I go, then it's my turn. And these are things that we don't wear on our sleeves because we have to survive, because after all, we have kids, we have bills. And thank you so much for mentioning financial abuse, because we don't talk about it. We don't talk about the fact that why isn't she leaving? Because she has nowhere to go, because her parents are fed up, because they didn't like him anymore, or they love him. So if she leaves him, she's not gonna have their support. She definitely doesn't have his support, because she's not even allowed to get into the bank account, or he has a different bank account. He's got more money than she does. We're gonna play big bank, take little bank. I've been for a lawyer, and I've been saving up for all these years, because I know what I know where you keep your information. Because when you were at work, I was hard at work as well, but I was at work making sure that I kept my phone. Because I will turn off the internet when I leave the house, because I know you have a Monday to turn it back on. You can't surf it. Because I took the keys to the car, and anywhere you go, you gotta either ask for a ride and explain, or you will walk. Because I make sure that if you don't cook what I want, you don't buy what you want. Because no, you don't need bra. Because no, you don't need shoes. Because no, we don't have money for whatever it is that you're asking for. This is a woman who sits beside you every single day, and she does a great job. And she smiles, and she's hilarious. And she's there for you, and you cry on her shoulder, and you tell her your problems, and she helps you. And she goes home, and everywhere her clothes cover her has a new bruise. And so she might sit by herself, or she might run out to her car for her coffee, for her break, and make a phone call. And that phone call is, somebody tell me I'm okay. I just need to hear from someone that is going to be okay. Right? But how do we support her if we don't know her? How do our workplaces become safe spaces? It's in the eyes. It's in 5 seconds of, how are you? And waiting for the answer, genuinely, in a moment where she's not under pressure, but in a moment where she's got a safe feeling. And she can trust me. And I think that we take for granted, I know that we take for granted what it means to pause and wait in discomfort. Being uncomfortable is not unsafe. I will be uncomfortable asking you if someone is hurting you, but not half as uncomfortable as you are when I ask you a question and you tell me yes. And be prepared for the no. Be prepared for the yes. Be prepared to ask me. Because your spirit knows. When you ask, you know. If you wonder, you know. We are empathic humans. We feel. You can mask as much as you want, but once you ask, because we've all done this, we've all done it. How are you? Oh, fine. How are you? Fine. How are you? We've all done that. We have all done it. Keep asking. Keep asking. It took me 21 years to call that number. My mother never did. My daughters never.
Hallelujah. Thank goodness.
Because everybody here is now equipped with that knowledge and now have the responsibility to ask her again and again and again. You can give her a code. I have a code. Mine is breakfast because I hate it. And my girls know, if I say, I want breakfast, she's not saying, call the police, something is wrong. I don't want hot sauce. Oh my gosh, she's dying. Get the ambulance. Right?
Right.
As a doula, I give every last one of my clients a word. And I tell them to give their husbands, their partners, whoever, their safe person a word. And when you say that word, that means clear the room, I need you. Get me out of here, I'm not safe. It's a word they can use in conversation or compensate or whatever. That one word can happen in the middle of a meeting where she looks down at her phone and he says something and she looks up. And she's like, this is it. This is that time. I know this is it. I can feel it. If I go home tonight, it's home. I know. When I felt that and I called the number, my life changed. And I'm forever grateful. Forever. Even in the safety now of having a protective word, of having spoken out and being in my own place and feeling so good and so strong, reaching into my spirituality, loving and knowing who I am and doing jujitsu and self-defense, all these different things, I still have to sit at this 1006 Michigan Street, 101 Michigan Street, in that court, in the courtroom, which is literally physically shaped like this, and looking at me, shaking, and smirking, watching me feel this power. Somebody else in here knows this. I can feel it. And what I want to say to you is call the number and then call it again. Because you're going to hang up the first time you call it. Because I did. And I hung up the second and third time I called. But I called back. Some of us never get a chance to call back. Sometimes you got to call for your neighbor. And I call for your daughter. What I want to share with you all is that the elephant in the room needs to be discussed every single day. Just like we can talk about sex with our children, our boys, our young men. Just like we can talk about birth control with our young men, with our boys. Just like we can talk about vasectomies with our young men, our boys. We need to be talking about financial violence, where someone is your slave because they are poor. Where someone has emotional damage because you say a word and it will send them into a frenzy because of what you did to them the last time. Every time you say that word. Because you can give a look and change the actual hormones running through a person's body. That kind of power is addictive to someone who is broken and who is violent and who is not help. And they need help as much as the people that they hurt. Remember that. But what I want you to take away from this more than anything else is that this is something we discuss all the time. Normalize that this is happening in our community. This is happening next door. This is happening to kids in high school, middle school. This is happening to people who look great, act great, perform great every single day. It looks like the woman that's next to you is all together, that we are all in the office jealous of. And so, standing here thinking about the first time I called and the people I was surrounded by professionals and feeling like I really wish I could tell her. I wish she knew that I didn't turn this in because I didn't forget about it. I didn't turn it in because I wasn't about to do something. What am I gonna prove it? How do I do that in a professional setting? What do we have in place where we can have conversations? Where in our workplace do we have space to have a human experience for 5 minutes and say, I'd love to go into this meeting, but at 5 o'clock, my life may change dramatically. You might not see me again. Got 5 for me? What do we have in place for that situation outside of, oh, calling the police? What do we have in place within our relationships where we can be a safe place for someone, even if maybe they're not our favorite person? But if we're a community of people who are serving other people, surely the person next to us can get 5 minutes in an office or a cubicle or a lunch or a meeting where they can unload and make a call. She might not be able to make to her car to make the call. She might not be able to step into the bathroom at work and look over all the stalls and see if there are feet to make that call and have her boss come in or have someone come in, right? What can we establish? We can establish safe words. We can establish and normalize. Let's do a little lunchtime together. Let's have a work buddy. Let's have work partners. How can we be more of a community? Put your phone down. Close your computer. Look your neighbor in the eye and experience her. And know that if you look her in the eye for 1 more second, she's going to burst. Grab her by the hand and tell her, you're gonna throw up. I need you. I need, oh, help me. And get in there and ask her what's wrong. And don't leave until she tells you. Because now we're all responsible. We have the burden of responsibility. Because none of us wants to be the one who's sitting at home, looking at the news, realizing, my God, I knew something was wrong. None of us want to be that person. But so many of us are, and we just don't know. I feel my story is victorious because I can stand before you and I can share this to 1 billion people, and I will, as much as is possible, in every arena possible, as deeply as I need to go, as deeply as someone else needs me to go, because again, my daughters and my son will not experience this. They won't. I declare that everything in it. That takes every last person in here sharing everything you can with everybody out there about this. It's very uncomfortable. We're uncomfortable. It's not unsafe. We're not unsafe until we're silent. That's what's not safe. We are not unsafe until we are silent. So I got loud and I made the call and I made friends for life. Safe within myself. I took back what was stolen from me and from my children. That was only by the grace of God. That was only by the grace of God. But I never want anyone to take for granted the fact that there's trauma all around us, even if it's not physical violence, even if there's not a death threat, the emotional violence and the depression, sadness, and poverty, and the generational lack that occurs because of just even emotional violence and financial violence. It's debilitating. We wear it in our bodies. There are so many different physical things that happen surrounding this emotional situation. We absorb all that energy. It has to go somewhere. So my ask of you, my call to action is to be someone's safe place. And if you need a safe place to reach out, that is my call to action to every person in this room. Thank you for listening. I thank you for caring, but I thank you more.
So I want to open it up to questions for these two lovely ladies. Anybody have one? I will come to you. Or comment? It's a very proudly vulnerable moment. I think we're all incredibly moved by that. Yes. Kelly, yes, I think you want to show our eyes. Oh, thank you.
I might cry too, but I want to ask the question. So I'm wondering if either of you have any guidance for us, and by that I mean I'm a nurse who works in a hospital setting, so we have patients for a short window of time. And sometimes, this expression you know in your soul, and sometimes you do, and you may not get them to open up or reveal, despite trying to create a safe space for them. So you can do some marginal education, but you will get so far, their answer is, no, I'm fine. Other times you get an admission of something that you could call mild violence, threat. I wouldn't call anything mild, but it might be presented that way from the patient. And it's not something that she believes needs action. The question is, in a short window of time like that, not an ongoing therapy setting, short window of time like that, what would be the most important messaging to her? Would it be about how she can respond, or where to get help, or just affirming her? What would you advise in that window?
I think one of the most important things, and thank you for the question. Thank you for the question. I think one of the most important things is to see her and let her know that you're seeing her. And by that, I mean, there's a pause and a smile and a look that is affirming, as in, I'm looking you in your eyes and I'm holding my hand in your hand. Okay. And that second of I see you, I'm pausing, I'm giving you my attention, and you know that there's a connection being made here without me saying anything. And oh, I just wanted to make sure you had this number. We give this to all of our patients.
And I think the other piece that I would echo would be as much as humans, our instinct is to demonize that other person, that is the quickest way to get a survivor to shut down. And helping that survivor understand that it's okay, and that one of the biggest and most important pieces that our staff will do is thank survivors for walking through our doors, because as you can tell, 21 years and probably several hangups, which is okay, that's what we're there for. They walk through our doors, and that is one of the bravest things that they will do in their entire life. And so never, ever, ever demonize that offender as much as you might want to. It's okay, they love that person. And I have survivors I've worked with for almost the entire time I've worked at the Family Justice Center, that they will never tell me that they hate that person. And they will continually to this day say, I love that person, because at the end of the day, that person gave me my children. And that's powerful.
Questions? That's a long way down.
I want to thank you so much for your transparency and your truth and sharing your story. I know it has impacted me, you know, being from an environment, I've saw a lot of the things that you described, right? And so therefore, I had empathy and compassion because it was very similar. People who have been in those situations recognize other people. And so what I'm trying to say is I worked another baby at Memorial. And a lot of times, to be piggyback up to the lady's question, how do you, or what do you do in those situations? Many times when they deliver, you got the whole family around them and it's a good time. But I worked night shift, I worked 7 p.m. to 7:30 a.m. So a lot of times when I had a suspicion or I thought, because I could recognize it, even though the whole room was saying joy, 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 and they're passing the baby around, you could look, distinctly see that something else was going on. So I intentionally would go into the room at different times when I saw the partner or the family lead and say, just sit with her quietly and say, is there anything I can do for you? Is there anything you need? Can I, just simple as just providing the care for her. Can I brush your hair? Can I help you go to the bathroom? In those moments, you're showing compassion, you're showing empathy, you're building a rapport, and she may, or he may, sometimes this man is being abused as well, but they may feel more closer to you to share because you're not judging them. You're just coming to say, I'm here as a support person for you. So in my experience, that's what has helped with me. And people will say, you don't even realize what you're doing, but they appreciate, they always remember those people who saw them, who heard them, who made them feel valued. And so I always say we're all sisters from another mother. The biggest thing we can do for each other is be kind and show empathy and compassion for each other. That opens up doors for people to want to speak with you. And so at work, I'm proud to say I work with Beacon Community Impact for Beacon Health System. And my supervisors here, I have the most supportive group of people working with me. And I deliberately, intentionally make time for each and every one of them if they want to talk. Or sometimes I'll just say, come walk with me, let's talk. And it may be nothing, they may not want to share, but just taking time to let them know that they're valued.
Absolutely, thank you.
Hi, thank you so much for sharing with us. I wanted to ask if you have any advice for those of us who go into people's homes where the violent partner may be present and we can't get them away from them. We haven't had that yet, but just to be preemptive about it, do you have any advice for us on that end?
I absolutely do. And so as Jessica was saying, you never want to demonize that person. And it's a very intrinsic thing, it's a natural thing when you feel like, okay, this is somebody who is got some not nice ways, but you feel it, there comes this, they can smell your suspicion, right? Like blood in the water to a shark. Your eyes change, your posture changes, so you respond to that physically when you see that. When you catch yourself doing that, tell yourself, I am safe, I'm okay, and I'm gonna walk through this. Because if you make yourself safe, and if you let her know that you're safe and she's safe, we're all good here. You want everybody to be relaxed. You want him to know, you are so funny. You figure, I'm gonna fall asleep tonight. You are ingratiating yourself, because that's what happens, right? They ingratiate themselves to you. They are charming, they lay it on. You charm too. I'm your friend. I love you all. I'm your buddy. We're gonna have Budweiser at the slow. We're best buds, right? Because if they know that you don't trust them, you have become the enemy, and he will put a wall in between you. So you are his best friend. Dad, let's talk about how we're gonna do this for mom. Dad, let's. And so you're making this a whole family affair because you're getting closer. He's gonna trust you. He thinks you have no idea. She knows that you're a safe person because now when you talk to her, he doesn't feel any type of way, right? And so it's not that you're doing any lying or you're not doing anything false. You are being open and safe for everybody so that you can get as close as possible.
I think that's impeccable advice, and always having a safety plan in place for your staff and yourself, but also working to be intentional around what that could look like going forward. Because sadly, we have seen incidences that might involve those types of situations, but working with the survivor and maybe coming up with creative solutions to bring that situation out of the home in any possible way. If that's a really cool event that you guys can meet at, or trying to get it out of the home. We've had a couple of cases in the past few years where offender just wouldn't be visible and would be listening, and also being really intentional about, like, if you have suspicions and you're not getting 100% clear answers, don't push too hard in environments you don't have control over. Because there's lots of spoofing that occurs, and there's lots of information that can be heard without people being present in the room. I worked with a clinician, and the other piece would be is calling us, engaging. I am more than happy. One of my favorite things that I did pre-COVID was meeting with the mother baby unit at St. Joe and staffing cases, because their biggest thing was, well, we have a NICU dad that mom's disclosed that there's violence, but she doesn't want to do anything, so he's getting irate, so we're just gonna kick him out. And my response to that was, okay, what happens when he shoots her in the parking lot? Because you have put up a wall, and we have to be strategic. It's all about strategy, and you have to be prepared to think 3 or 4 steps ahead of that abusive partner. And just knowing that all too often the abuse stems out of trauma, childhood trauma, other experiences, other things that have happened. And so being aware of that and kind of trying to feel that out. I think social workers are social workers and medical professionals are the perfect people to be kind of sussing these violent situations and violent relationships out, because it's all about refining your gut and trusting that instinct.
Okay, sorry. So I have 2 different scenarios. One is where it's a previous boyfriend who's been abusive. The one that she's with now is not physically abusive, but very mentally and controlling. And so I have my first question is, she has disclosed things, she trusts me, but how do I build her strength back a little bit? Because she's a little bit, like everything been taken away from her basically. So she's very small right now. So first of all, how can I help her to build back, get her strength a little bit more? And then she said a thing to me once that this current relationship that she's in, she would rather be in a physically abusive relationship because it's a one and done versus this constant, like just breaking down, constant fighting, it's just constant. And before it would be one and done, they'd be fine. And then one and done again, kind of thing. And then I have another client who is very new to me, but she is in a physically abusive relationship, and she just found out she's pregnant. So there's that bond that's gonna bring her closer to that person again. So I guess just how do I go from knowing what's occurring and them not being ready to leave, like that middle ground, I guess. If that makes sense.
I think specifically with the one that's would rather be in a physical violent relationship, that one's gonna be all about time, slow burn, slow, consistent communication and continuity of care with her. And if you can soften that approach, maybe seeing if she'd be willing to call our family justice center, maybe if she'd be willing to come to an appointment with you. Like, we allow support people in our conversations. We do have advocate confidentiality, so we would need to have that conversation with the client. But it's all about creating soft approaches as they're ready. That's the hardest thing for any human is to want something for another human and not be able to convince them that it's what they need to do. And that is, and in domestic violence cases, that it's not our role, is to step in and take power from them as somebody else has already done. It's to walk alongside and bolster as we do. The other relationship that you were talking about that just found out that they're newly pregnant, my often experience is that you'll see a break, and then we see maybe a protective order filed, or a kind of a hard line in the sand that'll occur, maybe due to an incident or whatever. And then you'll see the re-engagement of the relationship right before baby's born. And so it's that same kind of approach of that slow burn, really creating consistent communication and knowing that they have a support system and that they can come and talk to you about it, and then tooling them with strategies. I'm pretty hard about information when it comes to paternity affidavits and what that looks like, what rights moms have in the state of Indiana, and all of that, those different pieces of information that can tool survivors. I've worked with clients that I know, they have told me, I'm not strong enough to tell him he can't come to the birth of the baby. Okay, then where are you gonna deliver? Do you want him signing the paternity affidavit? No, I don't. I'm not prepared for that. I wanna deal with that in a separate situation. Okay, we prepared the hospital to be ready, and the registrar's office never visited that room. And in most situations where they don't know that that's a part of the process for dads, it's not a big issue, and it can save mom a whole lot of hassle and rigmarole on the back end so that they can make clear and concise decisions down the line. So it's all, at the end of the day, I'm gonna say strategy, accessing information and education for survivors to make the best next decision for them. And patience, yeah, lots and lots of patience.
I really have to say this because it just hit my spirit really hard. This is heavy. So if it is triggering you, it's time to step away and heal and deal with what comes up within you when you see this happen. Because if you work from your trauma, you'll hurt yourself and you put the other person in danger. Because I couldn't work with someone who had survived what I survived until I had really begun to go through the process myself, because I wanted to get help and I wanted her to get out of there. What was she thinking? If you're in a situation where you are healthy and you're not healed, you can do that because you're re-traumatizing yourself, and you may not be ready to support someone because you're not healthy. So I'm just putting that out there. If this is something that draws you to a place where you are unable to step away and be you and live your life, of course, you're gonna take home. It's right. But if you become obsessed with it, or if it's something that you can't get off your mind, put that out there.
Any other questions?
Is there a template for a safety plan with sort of guidelines and ideas that?
There's lots of options. I would encourage you to contact me, and I personally like to do specialized trainings with teams and tailor it to what your time frame is and what specific elements you might be able to be covering in a short amount of time, so that then your team can do robust referrals into the center, so that we're creating that. It's kind of like with law enforcement. We don't want to put too much on your team. We want to do that immediate safety and then transition them to the appropriate people. So I'd love to talk further.
Great.
I'm from Elkhart County. You only serve St. Joe County?
We do currently.
Extending that. Good.
So just a comment about depression screening. So I was hospital-based in Baltimore for 10 years and ran the screening program. And I will tell you, after doing thousands of Edinburghs, we also included some other questions about partner support. it was almost 100% of women who were reporting violence had off the charts at Bird scores. So that I think, you know, the lesson from that is that when you're seeing high Edinburghs or high depression scores, it is worth being open to the idea that there may be some things going on in the relationship. So, I mean, it's not predictive, but I do think that there are ways that people are disclosing that things are not okay in their life. And the screenings that we're all encouraging people to do, maybe another, maybe even if it's not, are you in a safe situation? Maybe some other ways that they're sharing with us. So that's more of a statement than a comment.
One, and it's just to echo on that specific piece would be making sure that if it's not their first baby, that you're actually looking at those assessments. Because I personally found that after my first baby, nobody even looked at mine. And so having that, because often we see in the domestic violence arena and in my time, I found that there's usually a trigger point where violence starts. If it's not the culmination of the relationship, you can see it after a marriage or the birth of a baby, or maybe it's the birth of the third baby. And so if we're not looking at those screenings and being attentive to them, no matter what pregnancy or birth it is, we could be missing the mark.
So we do need to wrap up. I would just love to leave everybody with one more little thing, that if you were to do the most basic safety planning with a woman that's not ready to take the steps of leaving this perpetrator, then what would you tell her of the most simple thing, other than I'm here whenever you are ready, but if you do have a moment alone with her in any capacity, what could she do to take forward to be safe in the future?
Where can you go? Who can you call? And how are you taking care of yourself mentally and physically? Those are that where can you go doesn't have to be long term, just short term, immediate safety. Even if it's, I worked with a client last week that she's like, I go to a street that's 3 streets away that he has no idea that that's where I would sit, and I let him cool off. Okay, if that's where you can go with 3 kids, fine, that's where we go. And so getting that immediate safety, but also being prepared to have the conversations around if they're still in the home and they're going to stay in the home because it's not safe to leave yet. So hard, blunt, sharp objects, as crass as it might sound, bathrooms, kitchens, garages, don't go into them. Try your best not to go to a second floor. Keeping the conversation, like our survivors know, they know by the way their weight shifts when they walk in the front door. And so being attentive to that and telling survivors, trust your instincts. Your instincts will help you stay alive.
All right, well, thank you ladies very much. Let's hear it.
Okay, we are beginning our wrap up of today. But before we do that, we are going to have you please pull out our best practices in collaboration for all of our community and providers in here. The object for this session is to apply the knowledge learned from the symposium and consider opportunities for collaboration that will improve continuity of care and outcomes for women and family in the communities. What we would like you to do is to join in small groups. I know that before we had our color groups. Some of us have since left our colors, left the building. If it is better for you to just kind of turn around the people that are near you. What we want to do is take about 10 minutes, group together, and go through these 2 scenarios. They're very different scenarios, but we want to take about 10 minutes and then we want to have a discussion based on what we can do to make best practices in our community here. So we're gonna take about 10 minutes. We're still gonna get you guys out on time. But let's take about 10 minutes if you can please group together, and we're gonna go over the first situation and the questions that we'll ask you to do in your small group. What, if any, biases come to mind when hearing this scenario? What other information would you want to know? And what organizations would you want to collaborate with? Or do you collaborate with when putting a plan together? Okay, so let's take about a minute and gather with a group of people nearby you. And then we're going to take a few minutes for you to go through these 3 questions, and we'll ask you to have someone from your group share information. Okay? If it's okay, these are going to come to you in your groups. And if you feel willing to share one of the questions, answers to one of the questions, or thoughts that your group had, I think that'd be great so that we can all learn from each other. On the first case, was there any bias that your group noticed that came out? If you would like to answer.
Yeah.
If not, you can pass.
So for scenario 1, some biases that we stated was that she's a Mexican American, so it's not uncommon in Hispanic families that you need to be strong, like you keep things in the family, you don't talk to others, you don't need therapy, like it's all in your head, things like that. That's a major one, I think. Yeah, that was our biggest one.
That's great, thank you. Do you guys have anything to contribute to the, what other information would you want to know?
Is this her first baby? Did she have support with her anxiety before the pregnancy? She went off medication. What did that support look like? Does she have, does she currently have insurance? We need to find out things for her. Okay.
What's the last question?
The last question is, what organizations would you want to collaborate with? Or do you collaborate with when putting a plan together? I'm taking mental notes on this one because I always want to build on what other people are doing,
Yes.
right?
It doesn't say that she has postpartum depression, but it says anxiety. So I would recommend her to, of course, we can create impact. We have unbiased. So we do have Embrace, PNCC, Roses. So I would suggest some of those, and then some things that you mentioned at St. Joe Health. So I would just provide her with resources and find out what she wanted to do.
So we still had some questions that we wanted to get from this individual before connecting her with organizations. So we want to know, is there a language barrier? Is transportation a barrier? And what is she looking for in services? Does she want something in home? Something telephonic? So once we get that information, we can connect her.
I had the pleasure of speaking last night, and that's actually something I mentioned last night. I'm a trained social worker, and I remember my first day of graduate school learning, start where the client is, start where the client is. Yeah, I see lots of nodding. Yeah, what a great way to be able to start. We may have all of these resources and programs that we can give, and we're gonna get you guys more information today, but what does she want? What fits well with her as we're looking at social determinants of health? What's gonna fit well in her lifestyle? Yes, the girl next to you is like, yes, preach it, yes. Fantastic. I wanna give honor to this side of the room. If there's anything in the back here that you guys would like to contribute before we jump into the next case. Anybody over here want to contribute to one of the questions? Any answers that you guys came up with?
Yes, you mentioned just meeting with the baby's doctor and figuring out a life plan and teamwork, kind of that collaborative approach with what they might be needing and getting a support system in place after they get home. Finding a medication she might feel comfortable taking, if any. Yeah, postpartum doula to have some home support would be good, probably.
Great.
We had some questions also just kind of about, you know, what legal status is of her. Also, something that jumped out for us was that she has not slept for 3 days. And if she's in the hospital and hasn't slept for 3 days, that's something major that needs to be addressed because of the potential for suicide. And then also, you know, what caused her to stop taking the medication? Because we have heard all day, you stay on your medication when you're pregnant, that's okay. And so what was the, what caused her to go off the medication, and who do we need to reconnect her with to get her back on her medication, who prescribed it in the first place. And then what were.
Oh, I was gonna make mention like La Casa de Amistad is a great service. We have it here in South Bend, luckily enough, and also in Elkhart, I believe. And I would also give a shout out, I guess, to Healthy Families because they are available throughout Indiana. I am bilingual, so luckily enough, I do get to serve a lot of Spanish-speaking families. If you're more of me, I guess that we're bilingual, that would be great too. But yeah.
Fantastic, great discussion. Wonderful. I'm loving this. Let's stay in our groups. And case 2 is a little bit more complicated. So let's go through case 2 for a couple of minutes. And I'm hoping that we can have some really good discussion with some of those same questions afterward as well. So I'll give you a few minutes in your groups to work through case 2, and then we'll come back and discuss some things. Man, I know I've seen one of these situations before. Yeah. So instead of starting in the front, I'll be like my kindergarten teacher and always started with the last name, so the back of the room. If there's anything that you guys would like to contribute to these last 3 questions. I'd like to start with the biases because I think that's pretty important. So you'll go for the second one. Any takers up here for feedback for the biases? Great. So with that one, I think we're looking at cultural biases, we're looking at racial biases, and we're also looking at an age biases. As somebody who had my first one fairly young, I remember that well. And I remember my pediatrician talking down to me and feeling that when I was on Medicaid and I was on WIC, I was treated very differently. And because I was young, I was treated very differently. So not speaking down to her first and foremost because she's 19, because there are 19-year-olds that are WIC smart, and we should treat everybody with that right from the get-go. And I think giving her that courtesy would be a big thing. And then also, she was the one who had given up, a couple of her other children too. So not making assumptions that she doesn't want to keep this baby, and just having those open lines of communication, ensuring we are doing what she wants to do and following suit with that. How about anybody on that side? Anyone want to contribute to this first question of bias as well?
We would like to add financial too, just to include and, and take that into account as well.
So maybe with question 2, more information that you want to know is with financial information. What does that look like?
If she knows how to apply for benefits, if she's interested in applying for benefits, does she know where to go? We were on the same page with finding out what she wants to do as far as raising the baby and going from there, following her lead with that and giving her the resources. If she's on the fence, giving her the resources adoption agencies and foster care and things like that, or if, and also supporting and encouraging, not encouraging, but giving her information on child development so that she has a better picture of maybe I can do this. And just giving her those support systems. I'm biased, I say refer her to us, because we can do that with her. I also said, we also said, as far as mental health goes, if she did come to our agency, we would do an assessment where we do the EPDS during the assessment, and if her EPDS is high, we do counseling referrals, we do an ROI. We ask if it's okay to send those results to a doctor, to a counselor, to Oakland, to any one of those places that might, if she's on a wait list, could possibly bump her up or put more of a focus on this person might need our help right now. So that was just kind of.
Fantastic. For those of us that are in the room that know Amanda Hammond, one of the adoption workers, right? Yeah. I know if she were here, she would talk about, gosh, the difference between placing a child and what that looks like, and the journey that that looks like, all the different ways that that can look like, but then also the opposite of that of parenting. Parenting is a huge decision, our two P's that we can talk about, and what does parenting look like for this person? What does parenting successfully look like? How can we help you make that successful, despite whatever past choices have been? Yeah. All right, how about question 2? Someone want to do
Well, basically, I just kind of want to piggyback off of what you guys already said, but I would like to know how she feels. I think with her situation, it would be unfortunate, but she may be dismissed, like her choices have already been made for her. And so I would really like to offer a safe space and ask her how she feels.
You know, the therapist inside me is always screaming, yes, start with the client, just ask how they feel, yes. It occurs to me now, I didn't think about this earlier, to wonder whether she did place her first child for adoption or whether she was forced to by her mother. She was an underage kid. And how she then feels about her choices now and how to advocate for her so that she knows she has choices. And whether there's an antagonistic relationship with her mother, if the child was removed. I have a family member, the birth of a stepson of mine, and that mother had 3 children who were raised, 2 children who were raised by her mother. And I've always been interested, how did they choose that, or did they choose that? It's not mine to ask, but I'm guessing it was a complicated situation that led to that. Yeah, and I'm also big on language. How was that decision made? Yeah, what did that look like at that time? What do things look like now? Yeah, I like that.
As far as what more information do we want to know? And actually bias too, she didn't receive it prenatal care. It sounds like that can be a huge bias. Why was that? Was there a barrier to transportation? Did you not want to be pregnant, or did you not know where to get care? Do you have insurance? There's so many barriers that can be there. Yeah, and I think that can, or was there like trauma, experience that was preventing you from seeking healthcare? So I think that's a huge thing to figure out. Why not?
And approaching those why questions can be really delicate as well too.
Some other questions that we had regarding her support system. Knowing the scenario stated that she had access to Section 8 housing, but was her mother and her sister living in that Section 8 housing with her? Or was she going to be living in that home by herself with a newborn baby? Which makes a difference in terms of support systems and what you have access to and what you don't. So that's one of our questions.
Again, I love that question. What does that parenting journey look like for you? What does it look like over the next couple of days? What does it look like over the next couple of weeks or the next couple of months? And how can we make that successful for you? Jumping into the last question for the sake of time.
In your folders, there's another kind of little square QR code. And everybody can pull that out now, because this goes into that last question, in addition to what we want to do and have people kind of in a few minutes here, stand up and go over who they are and where they're from. So this is the QR code that everybody has. This is fantastic. It should be in your folder that you can pull out. And if you're doing this right now, I'll walk you through it. It takes you to the Indiana.gov. This is the St. Joseph County Health Department webpage. And the second icon that you see, it actually is blue and it says 2023 resource guide, I believe. You actually want to click on that, push the button of the resource guide, and it'll pull up 24 pages of resources within our area. What we want to do is make sure that people have access and give information to moms and know who the contacts are and how we can kind of work together for that. The last wrap-up question that I kind of want to talk about is, what are these best practices of these interagency referrals? I heard so many people say, I'm going to refer to Healthy Families or have that happen. What do we think about are the best interagency referrals and follow-up communication to make that successful? I may think I'm young, but I just turned 40 this year, which is still young and also middle-aged. But I like talking to people. I'm not a texter. You text me, I'm not going to respond because I'm a trained therapist. I like to talk to people. So I actually prefer to pick up the phone and talk. A lot of my clients don't. They will not answer their phone. They just want to text. And unfortunately, with my work, I don't have a phone that I can text them with. So many times I'll have to call Crystal or someone from an agency that has the ability to be able to do that. I work at a doctor's office. I don't have bus passes to get someone here. So I need to also make sure that SDOH, the social determinants of health, are met. So I need to collaborate with people. I know for me, that's faxing or calling Crystal or one of our colleagues over at Healthy Families. But how can we make this referral process better for all of us? Closing the loop. What does that look like?
Responding that you help somebody.
Responding that you help somebody? Yes.
I think part of it is really knowing what resources there are in town. So that QR code is really helpful, but I'm a tobacco education coordinator, so I'm really not even familiar with all of the resources that you guys may not even be familiar with me. So this is great, so we can all kind of know who we are and what's available out there.
Yeah, within that resource guide, you can see that there's phone numbers, there's email addresses, and just kind of closing that loop of, hey, I met with your patient. Let's see how we can work together with this in the future.
Or I received your referral and they're not responding.
Oh,
Like,
yes.
letting you know, I'm not certain that.
Yes, I've received this, I've acknowledged this, and I'm trying to get a hold of this person, right? I'm so grateful when people reach out to me with that, because then it's, okay, next time they're in clinic, I'll run down there and see, and lo and behold, the phone number changed. Oh, perfect. Let's restart this process to make this happen. Any other suggestions? Yes.
I can be loud.
Thank you.
Just trying to be aware of community resources outside of our hospital and governmental networks as well, because we do have private programs that can work with people. And we have run into, as a private practice, a lot of, we prefer to refer back to ourselves, which we understand, but when we are all providing different services, we can meet so many different needs if we're willing to see that and work collaboratively together.
Well, that's wonderful. And I do know that that resource is housed through the Department of Health, and that really is Sally Dixon. If you look on their webpage, it has her phone number and her email address. And that was really kind of created for this event, but that's not an exhaustive list. So if there's something on there that you don't see that should be on there, feel free to email or call Sally and let her know about that. I want to be cognizant of time.
So we want to do a very quick activity, kind of reference what you just said. There are different organizations who actually are present right now, and I don't know who's from what organization. So if you could stand, just designate one person from your organization to stand, introduce yourself. And if you have cards with you, if people could approach you afterwards if they want your information, that would be awesome. So not everybody had resource tables, so I'm just going to maybe move up this side and kind of work our way through. So if you're comfortable with that, stand, say where you're from.
I am from Mental Health America of Northwest Indiana, so I'm over in Lake and Porter County.
Hi, my name is Gia Lands, and we are with Health Link. We are at FQHC here in the South Bend, Mishawaka area. I cover St. Joseph County, so we have 4 locations here, 1 in Mishawaka, 3 in South Bend, 2 in particular on IUSB's campus. We just provide comprehensive healthcare to the underserved and underrepresented community. We also are, as an outreach team, we are certified as Indiana navigators, and for Medicare, we are career access counselors as well, or case access counselors, for a matter of fact, so we can help get patients or just community members signed up and enrolled into Medicaid, Medicare, and Marketplace insurances. So we do a lot within the community. We have a lot of different connections, and we're just really, really involved. So we usually have something, you can catch us on Facebook or flyers around into different places. So just look out for me. I do have a stack of cards. I will be your point of contact here in St. Joseph.
Hi, my name is Orange. I work as a yoga assistant. I'm a community health worker. I work with all the high-risk patients, but if there's any pregnant women who needs assistance, that's me. That's me. And well, my cards, I'm sorry, but I can give you my phone number and you can call me. And yeah, I would be happy to. I receive referrals, and we provide also financial assistance from the ladies that don't have Medicaid or Medicaid, and I help them with all the process for the financial assistance through St. Joe. The only 10 days that they need to have emergency Medicaid, but I can help them with that as well. So.
Hi, I'm Katie. I'm here with St. Joe Lactation. We offer free lactation services. We can do free phone calls, free in-office visits. We have a free postpartum mother support group, and we do free prenatal breastfeeding education classes.
My name's Sandy Pontius. I'm a tobacco education coordinator. I'll just keep it going. I also work with St. Joe. But I help people quit smoking, and I also talk a lot about second and third hand smoke and not access to that, but coming across that, keeping it out of your home. I do have some cards in there, so if anybody, works with anyone that is a smoker that needs to quit smoking, nicotine is the gateway drug. So, I'm more than happy to help. I refer to the Quit Line, which is a free resource from the state, and I also facilitate Courage to Quit classes locally, which is also free, 6-session, kind of a group program, but it's very successful.
I'm Jackie Lott. I work at Oakland Elkhart. I'm a therapist for adults there. I also see families. I mostly work with women who have PTSD, and I run a group there about trauma and healing from trauma.
Lisa, do you mind if I
Go over to your chair.
I introduced myself already, but my name is Patty Miller. I work at Beacon Hospital, and I run the Mother Matters program, which is a warm line It's a lot like the PSI hotline, but it's just a warm line. I will call the person back, but answer during the weekdays, and I provide resources and referrals and a therapeutic service over the phone for any mom who is experiencing perinatal mood disorders.
I'm Kiana Jackson with Youth Service Bureau in St. Joe County, and I run a Young Mother Self-Sufficiency Program, which is case management, and it's a voluntary program.
I'm Nicole Mentag. I'm a nurse in the forensic department at St. Joe in Mishawaka. Our leader, Nancy Grant, she had to leave because she has to work this evening. But she had our cards over there, but we see all types of patients, domestic violence, child abuse, any acute issues or non-acute. So any patients that you have that and they need a medical exam, we see them, and then we also provide resources that we connect them with wonderful people like you.
There are 5 of us here from Healthy Babies, part of the Elkhart County Health Department. And we provide prenatal care coordination. So when a mom finds out she's pregnant, we can help her find a medical provider, do a Medicaid application, and then ongoing education through pregnancy and newborn, and help her get set up with other community resources and baby care items.
I'm Rachel Rose, also with St. Joe. I coordinate our perinatal hospice program, and if you would like to know more about what that is, you can chase me down.
I'll go over here.
We are Healthy Families. It's a home visiting program for prenatal women up until age 5. So if you would like your referrals given out, we give out referrals every home visit. So that is a big part of what we do. I made sure I took everybody's flyers who was here, and I will get this to home visitors, but we will be happy to hand out your information.
I'm Melissa Holbreed, and I'm here with Leslie. We are both from Beacon Medical Group Midwifery Centered Care. I'm one of the midwives, and Leslie is our wonderful office nurse.
Hi, I'm Becky Fulmer with the Shaw Center for Children and Families. It's kind of the research wing of the University of Notre Dame for psychology professors. So we run a lot of NIH funded grants out of there. The program that I specifically coordinate is called the Pregnant Moms Empowerment Program. And it is for currently pregnant women between 10 and 30 weeks who have experienced intimate partner violence in the past year. So we run a support group, and we actually do a lot of assessments pre-post group. It's a 5-week support group, and then we have them come in at 3.5 months postpartum and a year postpartum as well to do assessments to see whether or not the early intervention program has decreased depression in moms, has improved mom-child attachment, has improved, we're just now finding out a lot of the results because we're getting close to the end of this particular study. So, but we are still recruiting women to be a part of the program. We do pay them for their assessment time, so they can earn up to $400 or more for participating. We also provide transportation to have them come in to do assessments postpartum. And so I've got flyers out there where our tables in the room, so please send them our way.
Hi, everybody. I'm Kristen Sershin. I'm here with these 5 young ladies. We're with Milk Guide. We're a team of lactation consultants. We're private practice. We service from Fort Wayne all the way to the Port County up into Michigan. We provide home visits. We also have an office in Osceola as well as to Goshen. We love what we do. We also have a free clinic day every Monday at our Osceola office. Our goal is really to make private practice lactation care more accessible. So we work with commercial insurance, most commercial plans. We're working on trying to partner. So if anyone has resources for grant writing or funding, so we can provide our services more in home, would love to connect based on that. But great to see you guys today.
Hello, I'm Dee or Deanna. I work with the Indiana Pregnancy Promise Program with AMA. So we work with women that are experiencing opioid dependency during pregnancy, and then we work with them for up to a year postpartum. You can refer your members through the referral that was on Camila Arnado's website.
whichever insurance they're connected with, they will be able to be connected with a nurse to work with. Also, I wanted to share, findhelp.org is a really good website to use for resources, and it helps with that closely.
Hi everyone, I'm Crystal Monin and I work for a program called Embrace. And Embrace, we work with pregnant and postpartum moms and their families. So you can refer women who are pregnant, postpartum, or maybe they have someone in their family who needs services for counseling. And then Amanda does Rose's program, which is a preventative program for depression in women who are pregnant. And
Great, thank you.
My name is Ruth. There was a group of 6 of us here, working with Nurse Family Partnership. Logan and Christina and I are nurse home visitors in St. Joe County. Carrie is a nurse home visitor in Elkhart County, and we had Margaret here who had to leave, who's a nurse home visitor in Park County. So we nurse home visitors, we start when they're less than 28 weeks pregnant and visit them in their homes, refer them to all these other agencies, talk about all kinds of things, screenings, development, the gamut until the child turns 2. And Nurse Family Partnership is in the process of expanding now into every county in Indiana.
Hi, my name is Kristen Lawrence, and I work for an organization called Neighbor to Neighbor here in downtown South Bend. And we are a post-resettlement agency that supports refugees and asylum seekers through relationship, education, and advocacy. One of the things that we have done this last year is I'm also a doula for 15 years and lived overseas for 10. And so we've kind of been working with Beacon to be a cultural liaison and accompanying women, especially women who don't have language ability and are using a language line into the hospital to have better outcomes for moms and babies and be able to follow through the next year of their lives.
I'm Beth Temple. I am a licensed clinical social worker with St. Joe. I provide behavioral health across the board, but specialize in maternal perinatal patients.
I am Tara Jones. I'm a midwife with Beacon in Elkhart. I'm also perinatal mental health certification. So I will prescribe and manage medications until we get patients in psychiatric care. And I will see them for psych assessments even before we establish their prenatal care if they really need medical.
The agencies and wonderful people here. Gosh, the last thing I wanted to say with this is, this was a very long and informative day. And I'm so grateful for that, and also recognizing that it's also been an emotional day as well too. Each one of us kind of wears the hat of our patients as we come in here. We're talking about what we can do to make that better, but then also our humans and experience our own things as well. So I would just like to encourage all of us in the work that we do to make sure that there's space for really good self-care. Today's been a really heavy emotional day. I know I found myself crying a few times. So if we can practice our own self-care, whatever that is for you. I know for me that this evening it's gonna be listening to James Taylor on my way home from here because I'm with my windows down. That always kind of helps me with kind of recognizing the work that I've done today, but then also rejuvenating myself as I put my next hat on of going home to be mom to my little ones. And just kind of recognizing, gosh, it is really tough the work that we all do here. It is so important. Gosh, we have justified that today, but it's also really, really tough. Just like we tell our moms they can't take care of their kids well unless they are taken care of well, that is the same with us. So finding those care techniques that are really good for us. Today is a really great day to be able to practice that.
Thank you so much, Jen, for moderating the session, and thank you all for being here and staying a little bit later. So you should all have gotten an evaluation link by email, and so if you could give us feedback about today, that'd be awesome. We moved the worksheets to give us feedback about the trauma-informed care, and that we invited you to do a QR code or write on our sheets that are now hanging in the auditorium. So if you feel so inclined to give some feedback on trauma-informed care on those sheets, that's awesome. And thank you so much for being here. Really appreciate all of you.